Hello. How you doing? I feel better. I feel I feel better to some extent. I'm trying to find how to share system. You can see my background. You can see crutches. Oh, how were you able to see? Oh Jesus! Oh Jesus! Oh Jesus! How are you able to see that? It was even at the. Yeah, so please, oh, I need that Haitian food. He said, I look slim. Yeah, so I need soup. Hey, how are you guys doing? Yeah, Antoinette, I see you. Yeah, so far so good. I just honestly, I was almost about to cancel this class because I was at the clinic. You understand, for checkup. So they did drainage today. There was a lot of more than 75 mils of blood on the leg. Because I was wondering why was I not able to lift it? You understand? Oh, I went. There was a whole lot of inflammation on it, but hold on. Yeah. I miss you guys too. So there was a whole lot of inflammation on it. So I had to. They did stops. Let's not talk about it. How are you guys doing? Good. Everybody has to be here because before the end of this class, I'm going to send a Google form for you to fill for your attendance. So anybody that is not here, it can be the end or maybe the middle, but I'll just put it for like 1 minute or 2 minutes. So please, you have to be attentive because I need you to be here throughout this class. All right. Let's jump in. We're already 1 hour behind. Let's jump in, please. Okay, let me see. You can see my screen. I shared my screen. Can you see it? Yes. Yes, perfect. 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 Let me see if I can do it from slideshow, from current slide. No, if I do it like this, I won't be able to see. Okay. I think this works. Okay. Hold on, I'm trying to reshape the entire thing. Okay, this makes more sense. All right, guys. So oh, we have a senior nurse in the house. Hello. Okay. So guys, today we'll be discussing the cardiovascular system. We already started last time. We are supposed to distinguish and define different concepts. Remember, what we are discussing today is anatomy and physiology. Anatomy is location, 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 and structure, structure, structure. All right, and physiology is what? Function, function, function. See the way I'm talking now? That is my physiology, right? If tomorrow you see me and I'm not able to talk, you'll be like, no, Nchebe talks normally. You understand? So when physiology starts going otherwise, it becomes what? Pathology. Hold on, please. Yeah, so today we are going to look at the heart specifically, describe the general location, size, and shape, and also look at the enclosures of the hearts. The reason is because if there is a problem, it becomes pathology. And what we are discussing is the normal. You understand? I keep making a mistake. I have a screen here. I have a screen here. I don't know which one I clicked for it to move, but sorry, I will adapt. It has been long. I had my life review. So, okay. So this is the overview. Cardiovascular system involves heart and blood vessels. Have we done this topic? Have I had this topic with you guys? No? Okay. Because it's sounding so familiar. Why? I thought I already had the class with you. Okay. So cardiovascular system involves heart and blood vessels. Why circulatory system involves heart, blood vessels, and blood. So the difference is just the blood. You understand? In the circulatory system, because it has to move. You understand? So for blood to move, it needs a pump and it needs a channel. For it to move, it needs a pump and it needs a channel. So the movement, the pump, and the channel is what we call circulatory system. All right. Why cardiovascular system is just the structures, which is what? The pump, and the vessel where it moves normally. Okay. So I have to, you guys need to bear it in mind because they may ask you a question on cardiovascular system and you may mistake it for circulatory system. Extremely important that you know the differences. So the major divisions of circulatory system is the pulmonary system and the systemic system unit. You need to be able to understand these two different concepts. When you're talking about, please, if you have any question, for people that have not been in my session before, just write your question on the comment section. I'm looking at it right now, all right? That's why it's up here. So just write your the question there, or any observation or a feedback, and I will definitely make a comment on it, all right? I usually use YouTube because I don't like distraction when I'm teaching. You can distract me by typing. That's fine. All right. So major divisions of circulatory system. We have the pulmonary circuit. We have the systemic circuit. The pulmonary circuit is the one that has to deal with what? The lungs. Anything pulmonary is lungs. All right. Why systemic is anything that is not the lungs. You get it? And systemic is more on the left side of the heart. You understand? So when blood comes through the right, it goes to the pulmonary. And after the pulmonary, it comes back to the heart and goes here to the left part of the body. You understand? Or left part of the heart. From there, it circulates round, even to the head and everywhere. That's what we call what? Systemic circuit. So it supplies oxygenated blood to all tissues of the body. You understand? And at the end of the day, it has to come back to the heart. You guys, you have to bear this in mind. All right. Now, we have the left and the right side of the heart. You understand? The heart is divided into the left side and the right side. All these things are fundamentals that you need to have in your mind. The heart is divided into left side and right side. The left side is the one that carries oxygen. Why? Because blood enters the right, goes to the lungs. You see? So the lungs is more like the intersection between the left and the right side of the heart. You understand? So the question you ask yourself, what happens in the lung? Why does blood need to go to the lungs? Blood needs to go to the lung because it gets oxygen. So that tells you automatically that, any blood from in the right side of the heart does not have oxygen. And any blood in the left side of the heart has oxygen. Chicken, and you're good to go. Do you understand? That's exactly what this slide is about. Sorry. Okay. So this is a schematic diagram of the cardiovascular system. You see how the heart is. You understand? This is the heart. This is deoxygenated blood entering the heart, the right side of the heart. This side is the right side of the heart. All right. Then the blood now goes to the lungs. You understand? Look at it. Pew, to the lungs. All right. Pew, 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 pew. It got oxygenated. Then pew, it returns to the heart again. Which part of the heart? The left heart. Right? Then pew, it circulates around the body, throughout the body, then goes back to the heart again, to the right side of the heart. So that's why it's called circulatory system. It goes round. All right. Extremely important that you understand this. Now, in terms of the anatomy of the heart, you need to understand where the heart is. The heart has a base and it has an apex. All right. The base is the wide, superior area. You see, the heart is like this. So the base, is this wide superior area. Unlike how everything is. Normally, superior is always the apex, correct? But the heart is opposite of it, all right? So the head is bent downwards. So this is the apex down here, and this is the base upwards. So the base is superior and it's wide portion of the heart. A lot of blood vessels go through it, all right? Large blood vessels. Why the apex is just the tapered end in the inferior left part of the heart. Very, very important that you understand that. Then the weight, 10 pounds, 3.5 in weight at the base, and 5 inches from the base to the apex, right? So this is just anatomy. You look at it, yeah? So the heart actually gets bigger with age sometimes, right? But at the end of the day, your fist is exactly the size of the heart, your own heart, your fist. So if you see someone that has a very big fist, that person definitely has a very big heart. Okay. So this is the position of the heart in the thoracic cavity. This is where the heart is positioned. I hope you can see my mouse. Can you see my mouse pointer, guys? Yes, I need somebody to type yes. You need to pay attention because I'm going to give you a review today. You understand? If we're able to finish on time, I'll definitely give you a review. Some review questions that's one of the advantages of the online when we do it online, because I'm always very fast when we do it online. So I need to know if you can see my mouse. Can you see my mouse? You need to type yes. Okay, good. So this is where the heart is. All right, this is the great vessels in the heart. Thank you. This is the vena cava. You remember the vena cava has up one and down one. This is inferior. This is superior. This is inferior. This is the right part of the heart. Right. This is the aorta that goes out, from the left part of the heart. This is the pulmonary trunk. All right. We'll discuss about it again. So this up part where these vessels are is known as what? The base of the heart. Normally, if you're in the lab right now, you are supposed to dissect the heart. So next week, we'll definitely dissect the heart. All right. So please try to remember what we are discussing right now. So this is the base, very, very important. This is the apex. All right. This is the base. This is the apex of the heart. Then this is the lung area. Okay. And this particular area is in the thoracic cavity. All this area is thoracic cavity. So remember, the heart is in the thoracic region. All right. So this is the heart enclosed within the ribs. All right. This is the third ribs. This is the second ribs. This is the first rib. This is the sternum. All right. And this is the diaphragm. Remember the diaphragm muscle, extremely important. You did it in AP1 class. Okay. And when we dissect the heart this way, you'll see different, the exact location of the heart. Looking at it from the anterior, look at it from the anterior. You see the different locations of the heart. But this is just anatomy. Let's discuss some anatomical structures of the heart. Extremely important that you know some of these structures. That's why they are colored, because they will come out in your exam. I'll give you some questions. All right. If we have time, I'll give you some questions so that you will understand what I'm talking about. So, first of all, we have the pericardium. All right. The pericardium is the wall that encloses the heart. All right. Inside it, it allows the heart to beat without friction. You understand? So it encloses the heart, but still helps it to, expand and relax. Or understand, providing it room to expand, and does not allow it to expand excessively. Who's that? Are we going to dissect? Oh, yeah, I don't know. Anybody can just volunteer. Now, don't worry. We already have volunteers. All right. Somebody will volunteer their heart. We'll dissect it. Don't mind me. We are going to dissect sheep hearts. Yeah. So, so that's the inferiorly, that pericardium is sitting on the diaphragm. Inferiorly, sitting on the diaphragm. You understand? And anteriorly, the sternum is at the front. So the sternum is at the front like this. The diaphragm is below. You understand? Then the pericardium is inside like this. So if they ask you what is inferior to the pericardium, you're telling us it's what? The diaphragm. What is the anterior? You're telling us what is the sternum. All right. So we have the parietal pericardium. That pericardium is now divided into two. We have the parietal and we have what? The visceral. All right. So the parietal pericardium is the superficial fibrous layer of the connective tissue, while the viscera is the serous membrane covering the heart itself. The best way you understand it, let me show you. If you can see me very well. Okay. Let me see this medication, for example. Assuming this is your heart. Let me see. Assuming this is who should I use now? Maybe Sima. Assuming this is Sima's heart. Then I watch my hand. This is the pericardium. Look at it, covering the heart, right? Now, if you look now, you see there is an area of my hand, the palm area, that is touching this heart, correct? But this area is not touching it. Do you understand? This area is touching it. This area is not touching it. Because look at what they say. It's a double-walled sac. Double-walled. So this is the first wall outside. Then the second wall is inside. All right. So this second wall inside, holding directly to the heart, is not what we call what? Visceral pericardium. But this upper one that is not touching the heart, actually, but it's also a member of the pericardium, is known as what? Parietal pericardium. Sima, we have just dissected your heart. So I need you guys to understand the difference between parietal pericardium and what the visceral pericardium. Now, in between these two pericardium, that's this parietal and this visceral, in the middle, there is a space. That space is known as what? Pericardial cavity. Do you get? Inside that space, we have fluid, you understand, maybe between 5 to 30 ml of pericardial fluid, right? Inside that space. Very clean, septic fluid. No, not septic, aseptic fluid. What am I even saying? Aseptic fluid, no infection at all. So now, if there is an infection that enters inside it, what does it lead to? It leads to what? Pericarditis. Mind you guys, anything itis is what? Inflammation. Anything itis is what? Inflammation. You see? Inflammation of the pericardial cavity, we call it, or pericardium, we call it what? Pericarditis. Inflammation of the appendix, we call it what? Appendicitis. You understand? Inflammation of the vagina, we call it vaginitis. Urethra, we call it urethritis. So anything in inflammation is what? Itis. And inflammation are usually what? Painful. That's why you see some people coming to the clinic and they have serious chest pain. Most times, or a lot of times, it's always what? Pericarditis. You understand? Usually don't have anything to do with the heart, but has everything to do with that fluid in between the two pericardial what? Space. So you need to understand this thing. If you understand the physiology, you'll be able to what? Understand the anatomy. All right? Okay. So this is exactly what we are talking about. This is it. So you see, this is this is the fibrous pericardium. All right. Why this is the visceral. All right. This is the parietal, rather. This is the parietal. This is the visceral. Now the pericardium is also divided into three. You understand? We have the epicardium and others. But mind you guys, specifically, apart from the pericardium, let's talk about the muscle. You understand? This is even the muscle that I'm more interested in. Look at this muscle. 1, 2, 3. The most internal one, this is the most internal one, you see? Like this one now is attached to the papillary muscle. All right, this is the papillary muscles. If you can see my slide very well, this is the papillary muscle. So the muscle that anchors this papillary muscle, that's the most internal muscle, is known as what? Endocardium. You're in your exam, you are going to see this diagram, and they will point to this place. Guys, if they point to this place, they're talking about the muscle, not the space. Remember, we just discussed the pericardium now, and we talked about what? The parietal and what? The visceral. Look at the parietal pericardium and the visceral pericardium. All right? Very, very important. The parietal is outside, the visceral, that's superficial, fibrous. Why the viscera is what? The one that is inside, that's very, very attaching to the epicardium, but it's not exactly epicardium. Epicardium is actually the internal internal. Hold on, let me show you. Okay, look at the diagram. Look at the epicardium here. So there is a muscle here that is attaching to the internal part of the visceral peritoneum. That's what we call epicardium. All right. So epicardium, myocardium, and endocardium. So there are three muscles. In terms of their location, the most internal one is endocardium, followed by myocardium. So the most external muscle of the heart is known as what? Epicardium. But that most external muscle is attached to the most internal pericardium. I need you to get this concept, because if you don't get this anatomy, it will be difficult for you to get the physiology when we start talking about it. Muscle, there are three of them. We have what? The endocardium. We have the myocardium, which is the middle one. And we have what? The epicardium. Now, this epicardium is also attached to the most, to the deepest pericardium, which is the visceral pericardium. So the visceral pericardium and that muscle is attached together, and we call it what? Epicardium. Look at it here, epicardium. So I need you guys to get the concept, all right? So that's everything that this thing is talking about. So mind you, this pericardium, the external one is fibrous, the internal one is what? The internal one is what? Serous, all right? Okay. And the space between the two of them is what? Pericardial space. And I've told you the idea of pericardial space. So now, guys, let's look at more anatomy of the heart. Now we are going inside, all right? Remember, we just discussed what is covering the heart. Just like you want to talk about me, you talk about my clothes, and now we are done with my clothes. We want to go inside. Please don't go inside, though. I'm talking about the heart. Okay, so here we are going to describe the layers of the heart, the chambers of the heart, the features of those chambers, the valves of the heart. Why are we discussing this? We are discussing this because you are supposed to know the normal anatomy, physiology by 150, 160, AP1, AP2. All of them is discussing about what normal. If you don't know normal, you cannot know what's abnormal. That's what I told you last time. If you don't know normal, you cannot know abnormal. You understand? We know that the normal human blood pressure is, around 120, right? 120, 80. So anything above that, we say, oh, it's high, it's high, it's high. Pre-hypertension, 120, 130. Do you understand? 140, hypertension. Do you get? Why? Because we know the normal. If you don't know the normal, how do you know it becomes abnormal? So that's everything we want. So let's discuss the normal structures of the heart. All right? Normal structures of the heart. This is the cadaveric view. You will see it in the lab when you do the lab, which you must do. All right? So we already discussed our epicardium and endocardium and myocardium. We already discussed that. So look it up. The same diagram. Now let's talk about the chambers, guys. Please, whenever you need a break, tell me. All right? I don't mind. But we'll be fast. So let's talk about the chambers of the heart. So that when somebody comes to the clinic and tell you, hey, nurse, or doctor, I don't know. Yeah, they broke my heart. You should be able to ask the person, which chamber did they break? Do you understand? Or did they break everything? So that you know how to help the person. Do you get? If you don't know the chamber they broke, how will you know how to fix heartbreak? All right. So there are 4 chambers of the heart. Yeah, exactly, my friend. There are 4 chambers of the heart. We have the right atrium, we have the left atrium, we have the right ventricle, and we have what? The left ventricle. The atrium, A before V. A before V. Or A is above. So the atriums are always what? Above. Always remember that. A is always above. A before V. So the right atrium is here, the right ventricle is here, the left atrium is here, the left ventricle is here. All right? Extremely important that you know that. So what does that tell you? That tells you that any blood that's entering the heart is entering where? From the up to down. That's how life works. Entering from up to down, up to down, up to down. So all the blood that enters the heart, no matter where it's entering from, must enter from the atrium, right? Then move to the ventricle. Okay, that being said, if you look at the slide, it tells you that the right and the left atrium, there are 2 superior chambers. We already discussed that. They receive blood returning to the heart. Auricles seen on the surface, enlarged chambers. Then on the right and the left ventricle, they pump into the arteries, which makes sense. Mind you, what did they say? They said the right and the left ventricle pump into the arteries. So let's define this concept. The concept is that vein brings blood to the heart. Arteries takes blood away from the heart. Does it make sense? So vein brings blood to the heart. What does it tell you? Anything that is attached to an atrium. Okay, look at it. Vein brings blood to the heart. Atrium always receives any blood that's entering the heart. So what does it tell you? It tells you that all veins are always coming to the atrium. Check it out. Concept. If you know it, you know it. Fundamental, rationale. You understand? The vein is never attached to a ventricle. Ventricle is high pressure. Can burst that vein, whether it's coming or going. So instead, ventricles push blood through what? The arteries. So anytime you are doing the heart and they give you a label in the heart and you see that label is what? A vein. Tell them that vein is entering what? The atrium. There is nothing anybody can tell you. Say it confidently, authoritatively. All right? And if they point at artery, tell them that that thing is definitely leaving the heart. So you think about it. Which artery leaves the heart from the right? From the right. Where is blood going to again from the right? It's going to the lungs, right? Pulmonary, right? So the artery is what? Pulmonary artery. You see it? Wisdom. So any blood that goes out from the heart, the right part of the heart You understand? Has to go to the right ventricle, and from that right ventricle, it must go through what? An artery. Which artery is that? Pulmonary artery. Any blood coming back to the heart, okay, let me finish talking about going out. Another part of the heart is the left ventricle where blood goes out, and it must go out through what? An artery. Which artery is that? The aorta. So you see, the pulmonary artery takes away from the right ventricle. The aorta takes away from the what? The left ventricle. You must remember this for your exam sake. Bringing in the vena cava, which is the biggest vein, brings in to the right atrium. Then when blood is coming from the lungs into the left atrium, how does it come? It comes through the pulmonary vein. And that is one thing that we usually call a little anomaly. You understand? Because the arteries carries what? Oxygenated blood. Vein carry deoxygenated blood. But in the heart, the pulmonary artery takes blood away from the right ventricle. And that blood in the right is what? Deoxygenated. You see? So that's the only instance when you see an artery taking a deoxygenated blood out of the heart to the lungs. It gets oxygenated and it has to come back to the heart through what? The pulmonary vein. You understand? And it's already oxygenated. Means that pulmonary vein is the only vein that carries what? Like in a normal adult, the only vein that carries what? Oxygenated what? Blood back to the heart. So that makes sense. We've just defined a whole lot of concepts. And you guys have to remember this. Very important. So if you look at this diagram properly, I hope all of you can. Oh, okay, with all pleasure, I will. So look at it. Let me start with, if you have pen, it's little things you can actually write down. The right part of the heart, okay, first of all, the heart is divided into 4 chambers. So if say this is that, the 2 up ones are the atrium and the 2 down ones are what? The ventricle. That being said, remember what we are discussing is how does the heart move in a normal human being? If you know how it moves in a normal human being, when it moves otherwise, maybe when it starts going backwards, you say, no, blood is not supposed to go backwards. So you see, because you know that it should not go backwards. You know the physiology. So you'll be able to know the anatomy. You understand? Because after this, when you finish this class, you are supposed to recognize problems in the heart. All right? So that being said, all right, the right part of the heart receives deoxygenated blood. The left part of the heart receives what? Oxygenated blood. Okay. Any blood entering the heart must enter through what? The atrium. And any blood entering the heart must come through what? Veins. So that's the concept. Any blood leaving the heart must leave what? Through the ventricles and through arteries. Ventricles are only connected to arteries. So if blood enters the heart, that blood is deoxygenated blood and it's entering the right atrium, right? Then it moves to the right ventricle. And from there, it has to go get oxygen. But it has to leave the heart. Now it's leaving the heart. It must leave the heart through what? An artery. And it is deoxygenated. You see? Normally, deoxygenated blood is carried by what? Vein. But in this instance, it is carried by what? An artery. Which artery is that? Pulmonary artery, which carries the blood to the lungs, get oxygenated, and bring it back. You understand? And bring it back. And so if you look at it now, is it in this diagram? Okay, I'll get to the diagram. Don't worry. I'll get to the diagram. So what we are seeing here, very obviously, is pulmonary vein. Okay, so it leaves the heart, pulmonary what? Artery. You understand? So that is, I'm telling you that is usually in the body, arteries carries what? Oxygenated blood. But in this instance, and that is what they will ask you in your exam. In this instance, even in your clinical practice, you are supposed to know. In this instance, it is the pulmonary artery that is carrying what? Deoxygenated blood to the lungs. So when the blood is coming backwards, all right, it comes backward through what? Pulmonary what? Vein. That's why if you look here, veins are always depicted as blue because they are deoxygenated. But if you look at this thing, you see this is the left pulmonary vein, this is the right pulmonary vein. Do you understand? You see, the pulmonary veins are what? Red. Why? Because they bring oxygenated blood back to the heart, and it is not normal, but it is still what? Physiology. That's my point. So, okay, yeah, look at this. You see this blue one? This is what? Pulmonary artery. This is the only instance you see an artery being what? Blue. That's the point we are trying to make. Does it make more sense now? Okay. Now, before we continue, okay, so there's something we call atrioventricular sulcus. You understand? They separate arteries and ventricles. Then we have interventricular sulcus, which overlies the interventricular septum that divides the right and the left part of the ventricle. All right, right and the left ventricle. Interventricular sulcus. From the name, you will understand. Look at it. Atrioventricular. So it is in between the arteries and the atrium and what? The ventricles. Now, this is interventricular, in between the two ventricles. And also, sulci contains coronary arteries because they are outside. Okay, we'll still discuss about coronary arteries. So, but look at how beautiful this heart is. This must be my heart because I have a very beautiful heart. Okay, so if you look at the anatomy of the heart properly, you see what I was talking about. This is what. So you see this diagram. You're asking yourself, what is this thing? This is blue. So this carries deoxygenated blood. So this is obviously what? Pulmonary what? Artery. And what does it do? It brings it takes deoxygenated blood from the left ventricle, from the right ventricle to the lungs to get oxygenated. And this red one is pulmonary what? Vein, bringing oxygenated blood back to the left atrium. Very, very important that you understand. This is the left atrium or auricle. Now, this is the arc of the aorta, the biggest artery. This is the vena cava, the biggest vein. All right. Then this is apex of the heart. Yeah? Then this is the base of the heart. So if they want to break your heart, please tell them to break the apex. Eh? Not like it's not very important, but imagine them breaking this place. You understand? Imagine them breaking this place. We'll be calling 911. Aha. Okay. So this is the posterior view of the heart. If you look at it very well, you understand it. Posterior view of the heart. Now let's talk about the coronary vessels. I really want to shed a little light on it. So there's this woman that collapsed. I told you the story. The woman sells food and she collapsed. Why did she collapse? She collapsed because she was hypoglycemic. So somebody will be like, somebody that sells food collapse. Why? Somebody that sells food collapse. Why did the person collapse? Because she did not eat. Why is it that someone that is selling food will not eat food? Do you understand the point? So it's possible that that woman doesn't eat the food that she sells, right? She prepares the food, that she eats for herself, customized. This is not public food. That's exactly how the heart works. So normally the heart is a pump, but this pump carries blood from outside to inside to outside, from outside to inside to outside. That's how it works. But it does not take from that blood. You understand? It doesn't take from it. It doesn't cheat that quantity. No. Instead, it has a specialized vessel. And that vessel, we call that vessel what? We call it the coronary vessels. These coronary vessels. This is sinus here. These are vessels. All right. Very, very important. These coronary vessels. You understand? This is a sulcus here. This is sinus here. All right. And this area is the interventricular sulcus. But the most important thing I want to tell you is that the coronary vessels is exactly what is specialized to supply what? The heart. Very, very specialized. All right. So look at it here. Blood from the coronary arteries drain back to the heart via the coronary sinus. That's fine. But blood from the coronary arteries are what supplies the architecture of the heart. Extremely important that you know this. Supplies the architecture of the heart. So other things you need to know about the heart is the interarterial septum, right, which is the wall that separates the atria. You understand? Then we have the pectinate muscles, that's the internal ridges of the myocardium in the right atrium and the both auricles. Then we have the interventricular septum. This one is very, very obvious. Inter, in between the ventricle. Inter, in between the atrium. Simple. So this one, you don't even need to remember it. You don't need to think about it. All right. Then we have the trabeculae. All right. Also very, very important. They are just ridges that helps to prevent ventricular walls from sticking together after contraction. Normally, the heart does like chum 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 chum. Imagine the heart does like this and it's not able to separate. What will happen to that patient? Okay, you know. I know some of you are laughing right now, but you know. Now look at the internal structures of the heart. We've already understood the different regions: the right ventricle, the right atrium, the right ventricle, the left atrium, the left ventricle. This is the interventricular septum. You see it, interventricular septum, and this is the epicardium. This is the myocardium. This is the endocardium, rather. This is the myocardium, and this is the epicardium. Very, very important. Now, look at the papillary muscle. You see this thing? This is the papillary muscle. Guys, one thing you need to know is that any of these structures that has a problem, the person is having heart failure. You understand? And you need to understand what heart failure is. Heart failure is usually as a result of anything that will affect flow. Flow. Anything that affects flow is failure. Do you understand? Because you failed in your job, and the only job you have is just to flow, push fluid, pump blood. So anything that if you start complaining, like it's some students, we are doing exam in CSI, and imagine some students are sending me message, "Hey, professor, sorry, when is the due date for the assignment?" I did not even respond to those messages because, like, why are you asking that? You see it there. If I give an assignment in class, there is due date. So you see a due date, and you are due date that has expired like 1 month ago. You're asking me, professor, when is the due date? Like, you expect me to take my time and start sending a response? You understand? So it means that you failed in what you are supposed to do. So anything that makes the heart not to do exactly what it's supposed to do, we call it what? Heart failure. And what are some of those things? It can be the musculature. That's why we discuss the muscles, right? It can be all this septum. That's why we discuss the septums. Because look at this interatrial septum. If there is a hole in between these two things, what do you think will happen? Fluid will move from here. When deoxygenated blood enters the heart, it will move from right atrium straight to right ventricle. Sorry, it's moved from right atrium straight to left atrium. Then when it gets to the left atrium, where do you think it will go? It will go to left ventricle and go to the systemic circulation. So what do you think has just happened? It has bypassed the lungs. And when it bypasses the lungs, what happens? That means the blood that is moving to the body will become what? Deoxygenated. That's why you hear some people, they have a hole in their heart. A child will enter the clinic and you see the child bending, Valsalva. You understand? Why is that child bending? Because the child is trying to push systemic pressure backwards, and that pressure will close any hole that is here. So that blood will, instead of coming directly from the right atrium to the left atrium, it will go from the right atrium to the right ventricle to the lungs, then come back to the heart and circulate around that patient. That patient gets oxygen and stands up. So you see those children, usually children, you see them, they will always just want to sit down. Why? Because their body is not getting enough oxygen. It's just like they're choking you. You guys understand what choking is now? When they choke you, real choking, it's not that one that a lot of people are doing. Anyway, that's by the way. So I hope you guys understand the entire thing. So now, apart from the papillary, all right, these papillary muscles are also holding these guys. Why are they laughing? Also holding these guys are called what? Valves. So this is a valve, this is a valve, this is a valve. What does these valves help to do? These valves just helps to avoid backward movement. So when it opens up, loop opens up and blood pours into this guy, what does this valve do? The valve closes up immediately, so that blood doesn't go backwards, because anything going backwards in the body is a pathology. Think about it. Just think about it. You see some people, their urine, because of blockage, the urine is going back up. What do you think will happen? It will lead to infection. For real, that's how a lot of nephritis happens. Even urethritis, back up. All right. Imagine you finish eating, like the other day, I didn't tell you, my wonderful neighbor, here they treat me like princess. It's good to have very good neighbors. So I did not tell you guys. Don't worry, I'll just do in class. Let me not say it on YouTube. So that because if I see it on YouTube now, it will remain on YouTube. You understand? But my neighbors, wonderful people. They take turns. You understand? So one of my neighbors now bought me one very nice food from New Jersey. Yes, now princess. You know how you guys do princess now? Princess treatment. That's what they say now. You will never hear prince treatment or king treatment. It's princess treatment. Anyway, so she got me food. Very nice steak. Very nice chicken steak. It took 65 minutes for it to arrive. So it's very far from here. It's from, we got it from New Jersey. I was just salivating until that food came. That food came, I spread my legs and my hands, and started eating. I finished eating the food. I was very happy. Then I now opened the bag. I saw some things that they put in the bag, small container stuff. I was like, oh God. How come I didn't eat this thing with the stuff, right? So I just opened one and tested it. Just testing, my people. Just testing. Take it like that and throw it in my mouth. I swallow it. I take another one and throw it in my mouth. I say, please, I don't like this thing. I took all of them and throw it away. Less than 3 minutes later, I started having this throwing up feeling. Before you know it, I've gone to the toilet. All that food I ate. Jesus. I almost cried. Everything I ate, I vomited it. So the question is, well, why did I vomit? I vomited because of that little stuff I ate. I didn't know it's cheese. Right? I didn't know it's cheese. So when I tested it, I should have thrown it away. Yes, I am extremely lactose intolerant. I can vomit from now till tomorrow. You understand? Yeah. So why I'm telling you this thing is because it's coming back wet. Nothing should come back wet in your body. You see, apart from blood that circulates and goes back, nothing else should come back wet. From the same chamber, from the same vessel, nah, doesn't help, right? It becomes what? Pathology. So anyway, that's by the way. I used time to tell you about my neighbors, eh? Better go have good neighbors, so. Okay. So yeah, these are valves. There are two major types of valves in the heart and the areas of the heart. Two major valves. One, we call them what? AV valves, all right, and the second one we call them semilunar valves. If they ask you two types of valves, you should remember. Stop saying mitral, tricuspid, blah blah blah. No, you say we have two groups of valves. We have the AV valves, atrioventricular valves, and we have what? The semilunar valves. Where are the atrioventricular valves located? Atrioventricular. So atrium and ventricle, you see. So this is an atrioventricular valve. So this is the first one in the right, which we call tricuspid valve. All right. This is the one in the left, which we call what? Mitral valve, or what? Bicuspid valve, because it has double valves. This one is 3. All right. Very, very double cups, rather. This one is 3. So bicuspid, tricuspid. All right. This one is also mitral. These two together are called what? AV valve. So this guy is also referred to as right AV. This guy is referred to as left AV. So you need to know all their names. Left AV, bicuspid, mitral. Right AV, tricuspid. Those are the names you need to remember. All right. Now the second group of valve. Look at this one here. This is what? This is the pulmonary valve. Extremely important. You see, this is pulmonary valve. Then if you look at it beside it, do you see beside this valve is what? The aortic valve. Look at it. This is pulmonary, this is aortic. Pulmonary, aortic, pulmonary, aortic, pulmonary, aortic, pulmonary, aortic, pulmonary, aortic, pulmonary, aortic. Don't forget to. Where's everybody? Let me see my list. We are supposed to be 20 something here. Why are we? What's happening? Did they run away? They are not used to listening on this thing. Please tell them to come in. You are not here. You say you are here. I'm looking at the number of people here. You're saying, how far you say I'm here? I know you, how far I'm seeing you. But we are just 15 here. We are not supposed to be 15. You understand? We are not supposed to be 15. Yeah. Okay. Let me proceed. So those are the valves. Then the second valves are the semilunar valves. The semilunar valve is divided into two, which is the aortic valve. This one, and sorry, this is the pulmonary valve, and this is what the aortic valve. Very, very important. Pulmonary valve, aortic valve. Okay. So this is everything we just discussed right now. All right. Very, very important. Everything we discussed right now. And remember the caudate tendon. The caudate tendon connects the AV valves to papillary muscle on the floor of the ventricle. Look at it here. Look at, so this is papillary. Guys, look at the papillary muscles. This is the papillary muscles. This is the valve. This is papillary muscles. This is the valves. So in between these two, guys, we have the caudate tendon. These things are caudate tendon. Tendinous cord. Caudate tendon means tendon, a tendon that is cord-like. That's the meaning of caudate tendon. A tendon that is cord-like. Please tell your classmates to be here and active, because I'm going to ask some questions. I have to know people that are active, and attendance is mandatory. You understand? You see the latest memo? Attendance is mandatory. Okay. And remember, tendon connects a muscle to other things. All right? Okay. So we already discussed that. So I'm jumping all these things. These semilunar valves. I've already told you about the semilunar valves. Right? So they'll give you something like this kind of diagram in your lab exam. You'll be seeing this is the right, this is the left. This is the mitral or bicuspid, this is tricuspid. All right. If you look at it, what do you see? This is have one cups, two cups, and three cups. This is tricuspid. But look at this guy. He has what? One cup and what? Second cup. It's wider, but it's one cup, second cup. That's why it's called what? Bicuspid or mitral or left AV. But look at this guy. This is what? The aortic valve. How do you know that this is the aortic valve? You know, because this is red. Look at it. It's red. Aorta is oxygenated. This is red. But look at this guy. You see? How do you know that this is pulmonary? Because it's going to the lungs. So this is pulmonary artery. You understand? Valve. All right. Going to the lungs. And if you look at it, it's deoxygenated. Okay. I hope that works for all of you. Okay. So this is how it moves in the chamber. All right. The ventricles relax. When ventricles relax, watch it boom like this. When ventricle relax, the pressure in the ventricle does what? Drops. You need to pay attention to this so that you'll be able to catch this thing very, very well. You see, I'm speaking very slowly because I'm tired. I'm extremely tired. So I was discussing with my surgeon today. I told him, for the first time, I'm having headache. Like, since I came to the US, I've never had taken Tylenol. And right now, I take Tylenol almost 2 times a day. What is wrong? I'm not having this incessant headache. It's as if I'm choking, as if I'm dying. He said it's the anesthesia. I said, the anesthesia that I did, surgery I did last week, the anesthesia is still in my body. He said, yes, it will be in my body for like 1 month or 2 months. I said, hey! So today, he wanted to inject something. I said, what is that? He said, anesthesia. I said, no. I want you to do that drainage without the anesthesia. So they actually drained me today without anesthesia. Imagine. I'm crazy. The doctor said I'm crazy. I have high pain threshold. That's just the thing. So, but it was better because like I've not even gotten myself from the one he did last time. You want to do another one? See? Anyway, guys, I need you guys to understand this concept very well. You understand? When the ventricle relaxes, they will ask you. Yeah. So they will ask you, one of the following happens when the ventricle relaxes. One of the following happens when the ventricle relaxes. One, the pressure drops inside the ventricle. right? But it makes sense. Look at this bottled water now, for example. Hold on, let me show you something. Look at how it's disfigured. Eh? Why is it disfigured like this? Because there's a high pressure inside. I contracted it. I sucked out air, increasing the pressure. Make sense? If I want this pressure to drop, what do? I relax it. You see? The pressure has dropped. It's relaxed. So most times when you are drinking water, you're actually increasing the pressure in that environment so that water will come out. Or more so, when you are bringing that water out, you are increasing the pressure. So that's what happens here. That's exactly what happens in the heart. All right. So if this is ventricle, initially the ventricle contracts. It contracts. You see, high pressure. Then it relaxes. So the question is, why is it contracting and why is it relaxing? It's contracting because it's pushing out blood. It's relaxing because it's opening up to accept blood again. So if I'm pouring water inside this thing now, it's relaxed. I'll just be pouring water because it's opened up, it's relaxed, it's dilated. But when it's contracted, it pushes out blood. That's exactly, if you remember this concept, you will definitely remember what exactly happens to that. Without cramming it, you don't need to cram it. I mean, in your exams, there are a lot of technicalities. That's why if I have time today, I'm going to show you some of them. All right? So the pressure drops inside the ventricles. Semilunar valves close as blood attempts to, back up into the ventricles from the vessels. And what happens? The AV valves open. I need you guys to get this thing. If the ventricle relax, remember the AV valve is above the ventricle, correct? So if the ventricle relax, why is it relaxing? As I mentioned initially, it's relaxing because blood has to what? Enter. And where is that blood entering? It's entering from the what? Atrium. So if that is entering from the atrium, that means when ventricles are relaxed, that valve that is above the ventricle opens up. And what is that valve? The AV valve. So immediately it opens up, ventricle relaxes, valve opens up, blood from the atrium enters inside the ventricle. Enter. Once the ventricle fills up, this valve closes. And once it closes, the ventricle will squeeze itself. And when it squeezes itself, the valve below it will what? Open. So that makes sense. You ask yourself, which valve is above? The AV valves. Which valves is below? The semilunar valves. So when ventricle relaxes, the AV valves open and the semilunar valves closes. Wisdom. That is what they will ask you in your exam. If you are listening to this, and I need you to do like this and say wisdom, wisdom, wisdom. That's what you should be saying now. Let it be entering your head. So that it will be entering your head. Do you understand? Yeah. So let's go again. When the ventricle, this is the ventricle. You see? You see? So let's assume that this is the atrium. This is ventricle down. All right? This place, this location is the valve, right? So if the ventricle contracts like this, there's high pressure buildup. For it to press like this, that means this valve is closed. So ventricular contraction is equals to AV valve closure. So if this guy closes, ventricle contracts, and when ventricle contracts, the valve below is what? The semilunar valve. It will open. So what you need to be thinking is, okay, what happens to the ventricle? Anything that happens to the ventricle, you need to be able to equalize what happens above and below it. Chicken, and that's it. And you're good to go. So if you look at what I have on the slide, you see pressure drops inside the ventricles. Semilunar valves close as blood attempts to back up into the ventricles from the vessels. AV valves open, blood flows from the atria to the ventricle. They will tell you which one of the following is not true. Hit your head and say wisdom, 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 wisdom. Okay. What of when it contracts? I've already discussed it, you see? So when it contracts, the AV valves closes. For it to contract, that means you want to press out fluid. So first of all, it will closes the up one, press out the fluid, the down one opens up, and that it presses it out through the down one. You understand? So close open, press. So contraction works with AV closure, semilunar opening, and blood flowing out. That's contraction. Put your hand on your head and say wisdom, 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 wisdom. Okay. This is the blood flow, right? I don't need to read this thing. You guys already understand this thing, eh? So how, just look for number one. This is number one here. All right. Blood enters. We already discussed these things. Blood enters through the vena cava. All right. Look at it. Blood enters through the vena cava, both the inferior and the superior vena cava. Blood enters the atrium. From there, it bypasses this valve. This valve you must know. This is what? The AV valve, the right AV valve. That is what? The tricuspid valve. Then from this valve, it goes to the ventricle. From here, it goes out of the heart into the lungs. How? It bypasses this first semilunar valve, and this valve is what? The pulmonary valve, correct? It bypasses the valve and enters where? The pulmonary what? Trunk. This pulmonary trunk is divided into two, right? Which is the left and the right pulmonary what? Artery. It goes to the artery, to the lungs. Then in the lungs, they gather oxygen, right? That's number 5. They gather oxygen in the lungs and come back to the heart through the pulmonary what? Veins, as we've discussed. Look at it. Number 6, coming back to the heart. Which part of the heart do they come back to? These two, they come back to the left atrium, all right? They come back to this particular place, not this place, this particular place. So when they come back to this place, where do they go to? They bypass this valve. Which valve is this? The mitral valve or the bicuspid valve or the left AV valve. It bypasses it and enters what? The left ventricle. Then the left ventricle now pumps it. And look at it. This particular valve is what? The aortic valve. So blood bypasses this particular valve and flows into the aorta. This is aorta here, you see? Then the aorta now distributes blood. You see? We'll still discuss it during the vessels. Who is confused? Please, if you are confused, type confused. If you are not confused, type wisdom. I know you are laughing and you think I'm joking. Please type it. If I get 10 wisdom, we continue. 1, 2. I need to make sure you guys are active. This is the advantage of using Zoom, because I would have asked everybody to put on their video so that I'll know what you're doing. But I prefer this one because anytime you come back on my life, even in the next 1 year, maybe you are in the clinic and you want to think about what I said, you can easily go on the live and click it. See, that's the advantage. It's there, unedited, undiluted, just exactly as it is. Okay, I think 1, 2, 3, 4, 5, 6, 7, 8, 9. One more person. We have a lot of people here now. Are you sure you guys are? Anyway, I know when the number release, I'll just put in that attendance. Then some people will miss out and they will start sending me email. Hey, Professor, I was there, but it was the network. But then I'll just be laughing. Now I'm telling them to just be active for the next few hours. Trust me, we'll finish very fast. Anytime I do online class, I finish very fast. Okay, so this makes sense. Yeah, this makes sense. Now this bandage is disturbing my leg. Hold on. So 5% of the blood pumped by the heart is pumped to the heart itself. Eh? So I told you the blood that goes through the coronary is for the heart. You understand? Confirm. Thank you. So the blood that goes to the coronary is for the heart itself, and it is 5% of the blood in circulation. He said, "Did you do the attendance?" That means you are going off and on. If I had done it, I would not even say anything. I will still do it very soon. So please be here. So 5% of the blood pumped by the heart is pumped to the heart itself through the coronary circulation to sustain its strenuous workload. All right, 250 mils of blood per minute. You understand? Because the heart needs attendance. You know, the heart is doing a lot. No problem. I've not taken attendance. I will. Don't worry. So the heart needs abundance of oxygen. Correct? Abundance of oxygen. Why? Because it's walking every day. You think about it. Can you run for 1 mile? Okay, 1 mile. Let me say everybody can run for 1 mile. Can you run for like 2 to 3 miles without stopping? Think about it. But the heart is always doing like this. It's always jogging. Chakam, ichakam, 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 ichakam. Since you were conceived. Until it gets tired of pumping and the person will die. You see? Ichakam, ichakam. Where does he get that kind of energy to keep pumping? That's what we are saying. He needs abundance of oxygen and what? Nutrients. All right. So this is how it gets it. This is coronary. This is the anterior and the posterior coronary arrangement. All right. This is where it's explained properly. The left coronary artery, we call it LCA, which branches off the ascending aorta. Right. So ascending aorta, the left coronary branches off. You understand? Then it gives the anterior interventricular branch, which supplies blood to both ventricles and anterior to thirds of the interventricular septum. And also it has the circumflex branch, which passes round. Anything circumflex it goes round. You understand? And supplies the left side of the heart. All right. That one also gives off the marginal. So this is for LCA. This is RCA. Whenever you see LCA is talking about the left coronary, which gives the anterior interventricular and the circumflex branch. Circumflex branch is what gives rise to what? The marginal branch. Right? That marginal branch, which usually supplies the left atrium and posterior wall of the left ventricle. All right. Now we have the RCA. Very extremely important that you know the RCA. RCA is, is the one in the right coronary artery, which branches off the ascending aorta. So this left branches of the ascending aorta. This right also branches of the ascending aorta. But where does this right supply? This right supplies marginal atrium, right atrium rather, and sinoatrial node. That is the pacemaker of the heart. I'm still going to discuss it. Sinoatrial node is the pacemaker of the heart. All right. It is supplied. It's extremely important that you know these little informations, right? The right coronary RCA supplies the right atrium and the sinoatrial node. That's the pacemaker. It also has the right marginal branch and the posterior interventricular branch. You see? Right? Hold on. You understand? This is the left. You understand? The left marginal branch is from the circumflex branch of the LCA. It's a little confusing, guys. Just know that LCA is divided into anterior interventricular. Anterior interventricular supplies both ventricles. Both ventricles. All right? Why the left marginal, which came off the circumflex branch, supplies what? The left atrium. So that leaves us with the right atrium. So the right RCA supplies what? The right atrium. And what else does it supply? It supplies the pacemaker, because that pacemaker is in the right atrium. So the left atrium is by the marginal branch of the circumflex. And the two ventricles is supplied by the what? Anterior interventricular branch of what? The left circumflex artery. So I need you guys to understand this thing. If I'm you, I can just use pen now and draw LCA. LCA gives off Anterior interventricular branch. Oh, ventricle. Oh, it supplies right ventricle, left ventricle. Chickener. Then second one is what? Circumflex. Oh, circumflex, it gives off the marginal branch. And this marginal branch supplies what? The left atrium and posterior wall of the left ventricle, whatever. Left atrium. You just write it there. Left atrium. Then ask yourself, we've accounted for the right and the left ventricle. We are accounted for left atrium. What of the right atrium? You see? That is when you now go and write the left RCA. You write RCA. RCA also gives what? The marginal branches. And also it gives the posterior interventricular branches. But it gives off a branch that supplies what? The right atrium and the pacemaker. You are good to go. Check it now. Not too much talk. This is the classifications. Okay. Like when your heart is relaxed, that's when the blood goes to the heart to eat. It makes sense, guys. Look at what they wrote on the screen. Flow through coronary arteries is greatest when the heart relaxes. Flow through coronary arteries is greatest when heart relaxes. Which makes sense. Coronary flow, as I told you, is blood going to the heart itself. It's like the heart eating its food. Think about it. You now, for example, some of you guys are nurses, right? Yeah. So you are in the hospital, you are working. Your shift is 7 to 7, correct? Maybe you have a break around there. Let me see. When do you guys usually have break? Hold on, just a moment. I have a message. I have to tell them I'm on live. Yeah. If they need my this thing, they can come on live. Okay. Sorry, it's the physiotherapy. They're calling the hell out of me. They need my money. Say 11. No break. Oh, you want to have a break? What's the time? You want me to give you 15 minutes? But we've not even used up to 3 hours. Let me see. You're looking for break. We started by 2 now. We didn't start by 1. So that's between 1 to 2. Is it not break enough? We just spent 1 hour, 13 minutes. So no, at least let's spend 2 hours before you. 1 to 2, 2 to 3, 3 to 4. It's supposed to end by 4 now. 4 before the second section, because we are still going to do the second topic today. Okay. So as I was saying, as a nurse, you work, right, from maybe 7 to 2 o'clock, and they give you 1 hour break, right? That 1 hour. Okay, you guys don't get break at work? No, it's not true. You guys get break. What are you saying? You get break. How can you be working without break? 12 hours shift and you don't have a break. That's not possible. They'll give you at least 30 minutes break. That 30 minutes, you are relaxed, and that's when you start eating. And that's exactly what happens in the heart. Look at the statement again. The flow through coronary arteries is greatest when heart relaxes. That makes sense. When it relaxes, that is when it eats the most. So when they write that statement, tell them true. All right. So at that time, contraction of the myocardium compresses the coronary vessel arteries and obstructs blood flow. Opening of the aortic valve flap during ventricular systole covers the opening of the coronary, blah, blah, blah. Like, the most important thing you should know is that there is greatest flow during relaxation. Why? Because contraction presses this coronary vessel, so blood does not move through it as much as it should. So when the heart is contracting, the heart itself is not getting its own blood, its own food. All right. Yeah, and when that heart is, when that coronary vessels are obstructed, you understand, and the heart is not getting that flow, the heart will start complaining. That's why I told you that that woman sells food and suddenly she collapsed. Huh? She collapsed because of um low sugar is what again? My head is not working. Low sugar is high hypoglycemia. That's what I'm. Oh Jesus, that's what I was thinking about. So the woman had hypoglycemia, right? So just imagine the heart not eating its own food, and you are working 12-hour shift and you are not eating at all. You don't have time to even drink water. What will you do? Before you know it, do it one week. Try it 1 week. You work 1 week at a stretch, 12-hour shift without any break. Won't you resign? Think about it. You'll be angry. You will just call labor people and send them message so that they will sue your hospital. You know, here you people like suing. So yeah, that's exactly what the heart does. You understand? The heart starts complaining if it's not able to get enough blood is not passing through that coronary because of obstruction. You understand? And what happens? Once the heart start complaining by causing pain for that patient in the areas of the what heart. That's what we call a chest pain. You have person come to the hospital. I'm having chest pain. It's worse when I stand up. Blah 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 blah. That is what angina pectoris. Pain in the heart in the chest area. Remember, this muscle, this your breast muscle, is what? Is pectoralis major, minor. You understand? Major and minor inside. You get? So angina what? Pectoris. Angina what? Pectoris. This angina pectoris is pain caused by what? Ischemia of the cardiac muscle, cardiac architecture. The musculature of the heart is not getting blood and it starts vexing. It starts going on strike. It starts rioting like the railway workers. You understand? It can be partial obstruction. So angina pectoris can be partial. That's why some people be like, when they lay down, when they do this thing, they feel better. When they sit like this, they feel better. Do you understand? That's why you need to probe your patients very well so that you know exactly what's wrong with your patient. So partial obstruction. Do you understand? And when there's obstruction, the heart will now start working through what anaerobic what respiration. You say it happens all the time. It's the heart will start working through anaerobic what respiration. Why? It will start having fatigue. And that's why you're having that pain. You understand? Because it's producing what? Lactates. It's just like when you are running. Like me now, I run 3 miles without stopping when my leg was good. And I will start running again. Because if I can't run, why did I now do surgery? Anyway, if you see how the doctor was warning me in the hospital today, he said, Nchebe, don't run and don't play soccer. The guy took it personal. That's fair. Okay, so when you are running, right, why do you get tired? You get tired because your muscles start working on anaerobic respiration and start producing what? Lactate. That lactate is acid that goes to your joint and starts causing pain and fatigue, and you get tired. You don't have a choice. That's exactly what happens in the heart. Whenever you start having angina pectoris, know that your heart is getting tired. Why? Because it's not getting oxygen to its muscle. I cannot stay still. It's not in my nature. Okay, I know. I'll try. Today, I almost wanted to come around now, honestly. Almost. I thought maybe initially I was like, I said, no, 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 no. If I go there now, I didn't even know that they are going to do drainage today. I didn't know. You understand? It's just that I don't understand why I was not able to lift my legs since last week, especially this leg. So it was when they go to the hospital. The doctor said, there's a lot of blood inside. They started draining, almost 60 to 75 mils. Okay. He said maybe next month's story. It will shock you when I'll come to class before you next week. You guys are supposed to have an exam next week, right? Yes. Yes, you're supposed to have an exam next week. I hope you've been watching the videos I uploaded, though. I see the exam, nobody talk. Anyway, That is angina pectoris, guys. All right. Yes, you are supposed to. We are supposed to write the exam after the first 4 topics. Is it the second topic? No, hold on. Let me check. Yes, I know how far we tell me the truth. So we are supposed to have exam after the first 4. Okay, no, not next week. Not next week. Because we are doing circulatory blood today. Okay, no, it's next week. I'm correct. We did blood last week. So we are supposed to do the heart. No. We did blood last 2 weeks. Hold on. We discussed this thing before. Somebody saying how many chapters. We discussed this thing. Our exam is supposed to be after the first 4 chapters, which is endocrine system, circulatory blood, the heart, and blood vessel. So today we are doing the heart, but this heart was what we were supposed to do last week. So today the topic we are supposed to do is blood vessel, and which I'm going to do immediately I finish the heart. So your exam is definitely next week. Endocrine system, blood, heart, and blood vessel. It's next week. Thank you. We discussed it now. You guys think I forgot? My surgery was not in the brain. No. It's in the leg. It's on the leg, rather. Not in my head. Wisdom. Do you get? So we are going to do this thing. You know, that's why I put those videos, because those videos are your review. Can I do 3? 3 chapters? Okay. So what I will do, especially because this jam packing is not your fault, it's my fault. So it's not really my fault, it's just what it is. So, but it's not your fault. So your exam will be on 17, 18, 19. Make sense? So your exam will be on endocrine system, which the video is there. I'm looking at it now on your Canva. Your exam will be on blood specifically. Yeah, that's chapter 18. And also on the heart, that's chapter 19. The heart that I'm teaching today. I don't know if that's okay, because I think some people have already read the entire 4 chapters. They may be angry that I'm reducing it. So I need to know, if you want us to do the 3 chapters, I want you to write something, write wisdom. This wisdom thing that I started today. I don't know where I got it from. So I need you to type. Let me see the number of people that are okay with us doing just the 3 chapters instead of 4. Okay, so 3 it is. I see that there are too much wisdom here now. So please, guys, please. You see, as mean I'm strong. You know me now. From your second exam, I'll be giving you thorough review. But please, you were in class, so read very well. You have now till next week. You don't have a reason not to get a 90 plus in your exam, because the review video is there. I'm seeing it there. 3 review videos. You can also go, there are more review videos on the live self. You'll be seeing more review videos. It will be almost the same question, but there are other more questions. The more questions, the better. Just what you need is not slide. What you need is video. Slide is for me to teach you. Feel me? It's for me to teach you. You understand? But these videos are for you to learn, to make your preparation. If you keep doing it between now and next week, there's nothing on earth that will stop you from smashing your exam. As far as you were in the class, that's why you can never miss lecture. Lecture is, undoubtedly one of the most important things. If you are in your lecture, you do your lecture very well, you pay attention, you ask your question, then you go home and you read and recap. What you need now, in the eve of close to your exam, 1 week to your exam, is the videos. It's just questions, all right? So when you watch the videos, also go to the live. Like, for example, if you go to my live, you see live endocrinology. Please click it. It's your own. It's for you. You understand? You see the questions I throw, people are asking. You know my normal style. Please, you did AP1, guys. So you already have that the swagger already because you demolished the AP1. So don't let AP2, put down your confidence. All right? No. I won't be able to review, Sima. You understand? For this first exam, I won't be able to. I'm even trying to be here, honestly. You won't understand. But I really won't be able to review, honestly. Yeah, so for just this first exam, but from your other exams, I'll be doing your review. Do you get? So between now and next week, I don't want to make promises. You know me, I don't promise when I won't be able to fulfill it. So, but let's continue, guys. Let's continue. So, we've discussed angina pectoris, right? Chest pain from partial obstruction of coronary blood flow. All right. Now, if that coronary blood flow blocks completely over a long time, what do you think will happen to that heart, that muscle, that myocardium or cardium? It will what? Die. It's just like if somebody choke you. Think about it. The way you are doing choke me, the person choke you. And when you are telling the person stop, he did not hear that the person is already high. He did not hear that you stop and you die. You understand the point? That's exactly what happened to the heart. Now, a situation whereby the coronary vessels has been giving you signs through angina pectoris and the person didn't treat it. You are doing macho. You understand? Having pain and you are doing macho. Instead of you to come to the hospital and they will do you a scan and know what's wrong with you and know how to what is blocking it. You understand? Over a long time, the heart architecture will die. And if it dies, that's what we call what? Myocardial infarction. So you should know the difference between myocardial infarction and what? Angina pectoris. You understand? Myocardial infarction and angina pectoris. You said no review. I told you that there's already review. The review is on live. Just go and click it and watch it. There's a lot of reviews there for you. All right? It's the same thing with my review with you. The one on live is the same thing. So I don't see any difference. All right? The only difference is that you want to be seeing me live. But you will see me there also. Just pretend that it is live. All right? Okay, so let's continue. The question you should ask is, why will the myocardial infarction happen? Why will there be a sudden death of a patch of myocardium? Why will there be a long-term obstruction of the coronary circulation? One is atheroma. That's the most common. All right? Blood clots or fatty deposits. That's why when they like me now, when I last time I did test, I think last month, ending of last month, they told me I have a high level of LDL. You understand? At risk, high level of LDL, hyperlipidemia. That hyperlipidemia can progress, to the heart and cause what? Atherosclerosis. You understand? That is fatty deposit on the heart. You understand? If it continues going up, start blocking. So assuming this is the vessel, right? Then the thing is here. Continue increasing. The amount of blood passing here will no longer be able to pass here. So I'll start having chest pain, right? People start having chest pain. Let me not use me because I don't have it. You understand? Chest pain start happening because of angina. It start blocking. Before you know it, it can completely obstruct and it becomes a problem, especially the particular coronary vessel. So if the particular coronary vessel going to the left atrium, what will happen? that left atrium will stop having what? We stop having oxygen, and it's the muscle there will die. If the muscle there dies, will it be able to pump? No. So myocardial infarction can lead to heart failure. You need to be able to connect these things. So what are the things? Atheroma, which often blocks coronary arteries. Cardiac muscle downstream of the blockage, what? Dies. Right? So these two things are the major things. This one dies. There's heavy pressure or squeezing pain radiating to the left arm. Remember when we talked about radiating pain? Why? Because the brain is not able to, is confused. It didn't know that that thing is from the heart. Instead, it's thinking it's from the what? The skin of the hand. You understand? But that's what we call what? Referred pain. And that's the MOA, mechanism of action of referred pain. All right? So there's heavy pressure or squeezing pain radiating into the what? The left arm. Some painless heart attacks may disrupt electrical conduction. You understand? Pathways, leading to fibrillation and what? Cardiac arrest. I'll discuss cardiac arrest for you. And heart attacks. Yeah. So silent heart attacks occur in diabetics and in elderly, right? MI responsible for about 27% of all deaths in the US. You see, you can't take it for granted. You really cannot take it for granted. All right. So this is venous drainage. I don't really talk much about venous drainage, but you should also know that we have coronary veins, right? And most coronary blood returns to the right atrium by way of what? The coronary sinus. You understand? The coronary sinus, there are three main inputs. Right? We have the great cardiac, we have the posterior interventricular, and we have the what? Left marginal veins. All right? Look at that. Those are the three of them. Okay. Okay. So let's talk about conduction. When you talk about conduction, all right, remember, guys, we already talked about the anatomy of the heart. Now we are talking about the physiology of the heart. All right? We talked about the anatomy of the heart. Now we are talking about the physiology of the heart. And when you want to talk about the physiology of the heart, there are still some anatomical things that are very important. That's the structures. Now, the structure of cardiac muscle, if you bring out a cardiac muscle, what are you looking for in the lab? What are you looking for? You see that it is striated, right? Now, which other muscle is striated? Guys, type on the charts. Type on the chart, guys. Which other muscle is striated? I need to see 10 people typing the same right answer. Quickly. Are you guys on hibernation? We said the cardiomyocytes has striation. So the cardiac tissue has striation. If you bring it out, which other one has striation? You have to be typing, everybody, you have to be typing. Even the people that are shouting that, oh, there is no review. Now there is review. Type the answer. Quickly, guys. So, I want you to tell me what causes striation in skeletal muscle. Yes, I am. You are correct. Striation. We have striation in cardiac muscle and also in skeletal muscle. In skeletal muscle, what causes striation? Quickly. Somebody saying heart. Oh, that means you didn't listen to the question. I said we already seen that the heart is striated. Which other one? Which other tissue is striated? It can't be the heart now. So you saying the heart means that you are not listening. And yes, the answer is skeletal. But I'm asking, what causes striation in skeletal muscle? The chairman himself, I greet you. What causes striation in skeletal muscle, guys? Yes, it's skeletal, but what causes striation in skeletal muscle? Come on. Somebody said actin and myosin. Yes. Yes, that actin and myosin overlap. All right. Yes, that overlap is what causes striation in skeletal muscle. But when we are talking about the cardiac muscle, what causes that striation is intercalated disc. 911. Okay, that's fine. So what causes striation for actin and myosin is that what causes striation for skeletal muscle is the actin and myosin. You know, the actin comes like this, the myosin comes like this, and they overlap, right? You know, that's why you have the light band and the dark band, light band, dark band, light band, dark band. You understand? That's what causes that striation for skeletal muscle. But when you're talking about the smooth muscle has no striation. But when you're talking about the cardiac muscle, it also has striation. But each striation is as a result of what intercalated was disc. And what is intercalated disc? Intercalated discs are folds, you understand, joints or junctions, right? Where electricity also passes through. That's what intercalated disc is. All right. Now, the heart, when the heart has a scarring, it heals by, when the heart has an injury, it heals by what? Scarring. Or what we call fibrosis. If you look at your skin, sometimes when you look at your skin, you see some, maybe if you put iron on your hand, you know, people that are ironing their clothes, they mistakenly put iron on their clothes and their hand, or you mistakenly injure yourself. You see one black thing, that place, the hair does not grow. That is scar. Do you understand? That's exactly the repair. That's what we call fibrosis. All right. So the heart repairs entirely by what? Fibrosis. That's why you should not break anybody's heart, please. You understand? Imagine somebody that has already had like 5 heartbreaks. Ha. Okay, don't mind me. I'm just playing. So the heart has mechanical junctions, right? That are tightly joins the cardiomyocytes. We have the fascia adherens. We have the desmosomes, right? We have the electrical junctions. That is gap junctions, between two cells, cell and another cell in the heart. You know, that have a gap junction. Electricity passes through it. All right. Okay. So this is how the histological section of the heart is. If you notice very well, you see the disc. This is the disc. This is the disc. This is the intercalated disc. See, intercalated disc, striations, and all those things. Okay. Now, we already discussed that the cardiac muscle, you know, it takes oxygen, right, for its respiration, right, to make ATP. It's very rich in myoglobin and glycogen. Very, very important that you know this. Huge mitochondria. Of course, that's how it's able to pump. Imagine pumping forever. Think about it. Imagine pumping forever. No, not forever, until the person dies. Do you understand? You need energy to do that. That's why the mitochondria is very, very active. So, it's also adaptable. Apart from this myoglobin and glycogen, it's adaptable to organic fuels like what? Fatty acids. So if it doesn't have glycogen, you see immediately to convert fatty acid through gluconeogenesis to glucose, and it will use it to form ATP. Simple. Do you understand? So 60% fatty acids, that's 5% glucose, ketones, lactate, and amino acids 5%. You understand? Very, very vulnerable to oxygen deficiency. Fatigue resistance. Why does it have fatigue resistance? Because it makes very little use of what? Anaerobic fermentation. So usually anaerobic fermentation always happens when it has what? When it has a maybe partial closure of the coronary area. Do you understand? Or even full closure. That's why what causes what? Angina pectoris and also myocardial infarction. Remember that, guys. Remember. So it does not fatigue for a lifetime. All right. Okay. Another thing about the heart, when we talk about the conductive system, we talk about what the heartbeat. How does the heartbeat work? You understand? The heart has an internal generator, which we call what? The pacemaker, right? It's just a valvular conduction pathway, you know, in the myocardium. It's usually found in the atrium, right atrium specifically, because that is where the generator has to be located, just at the entrance of the blood, so that it can generate enough energy to push that blood down. And it will now spread its energy to other chambers of the heart. Very important that you guys know this. You understand? And this is the order. First of all, we have the SA node. This SA node is extremely important that you people understand it. I always call it the main wife. SA node. SA node is the peacemaker of the heart. In medical school, be like, you see a girl that you like, you be like, can you be my SA node? You see? Can you be my SA node? You understand? Then some people will be like, be wise or be careful. This person you are choosing as your SA node, be careful before the person will cause you cardiac arrest. You see, that's jokes we make in medical school. All right. And what do those jokes mean? It means that, okay, the SA node is extremely important. That is what generates power in your heart. If anything happens to it, cardiac arrest, death. See? And you need to know the location. What is the location? Right atrium, near the base. You remember I told you the base is up. So the right atrium, you understand, near the base, right, of the superior vena cava. So this is the superior vena cava. This is the inferior vena cava, entering the right ventricle. So that area of the superior vena cava is just below it, which makes sense because that's where a lot of blood enters from. Then the signals now spread downwards. All right, I'll show you the diagram. Then the signal spreads towards the AV node. The AV node. So we have what? The SA node, which is the main wife. Then we have the AV node, which is the side chick. I don't know why my phone is doing tom 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 tom. What's that? So where did I stop, guys? Just forgot what I was saying now. Okay. Yes, I was talking about the SA node, right? Yeah, and AV. So the power starts from the SA node and spreads downwards to the AV node, right? Now the AV node, I always call it the side chick. The main wife is the SA node. Always remember that. Always remember that. Like, you know, you'll be telling somebody, hey, I want you to be my SA node. You say, please, 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 you want to convert me to AV node because I know your SA node. You see, wisdom. So what does it mean? You can always remember this thing. If you don't need to cram it. Do you understand? You don't need to cram it. You remember it anytime, even when you are sleeping. All right. So this is the main thing here. Then this is the AV node assisting the main thing. This AV node is atrioventricular. What does it tell you? It's telling you that it's located around the AV valve at the lower end of the interarterial septum. So electrical gateway to the ventricles. This guy spread the electricity generated by this guy to the ventricles. Remember, this guy is this one, the SA node, is in the right atrium. That's why it's sinoatrial, sinoatrial, sinoatrial in the atrium. And it's the pacemaker. And where is it located? They will ask you exam. Right atrium, base, near base of the superior vena cava. Extremely important. But this guy is located a bit away from this other guy, right? So it's located in the right AV valve at the lower end of the interarterial septum. You understand? So power comes from the main wife and spreads a little to the AV valve. This guy helps to bring down everything. You understand? And also it prevents, you know, excessive currents from coming into the AV valve. So everything that's coming into the ventricles, all the power that is coming to the ventricles, it organizes it and sends it by itself. So it prevents currents from getting to ventricles by any other route. You know, side chicks, they are so jealous. They are more jealous than the main wives. Do you understand? This one we spread everything, but this one we want no. Anybody that's coming to this guy, we must come through me. That is what the AV valve does. Always remember that. All right. So from the AV valves, we have what? The AV bundle. This guy leads to this guy. This AV bundle, we call it what? Bundle of His. They are just bundle forks that branches into the left and right, right? Their branches pass through the interventricular septum towards what? The apex. So they are just like the conveyor. You understand? So when all the power comes from SA node, the AV node arranges that power properly, then sends it to the bundle of His. That bundle of His now divides into two. You see? It divides into two and comes back like this. All right? That's why we have, sometimes we say, oh, you do ECG. Do you understand? If you do ECG, because anytime you are doing ECG, you are checking for power. You understand? You are checking the electricity of that person, right? That's what we are checking, because if there's a problem with the electricity of that person, the person shuts down. Just like if Codedicine gives us cuts off power now, New York will become dark. That's how it is. New York will become black. You get? So the connecting of the heart is what? The SA node. So remember that. Connecting of the heart, SA node. Wisdom. Okay, guys. So this guy branches. That's why sometimes when you see that ECG, you'll be hearing right bundle branch block, RBBB. You see? Left bundle branch block, LBBB. I don't know if you feel it. So, that's what they're talking about. You get? If the SA node blocks, if the SA node blocks, what will you do? You see? Or the SA node is not functioning. You see us using defibrillator to do 1, 2, 3, boom, 1, 2, 3, boom, 1, 2, 3, boom. You understand what I'm talking about, right? Because we are trying to beg the SA node towards start powering again. And at that moment, when the SA node is not functioning effectively, the AV node is in charge. But the AV node is never in charge for long. I really don't want to go into it. So if you look here, you see what we're talking about. See the SA node, you see? SA node fires, right? Excitation spreads through the atrial myocardium here and here. But what AV is more interested in the ventricle, right? So SA can fire down here and this side. But AV, look at AV node here, right? AV node collects this power, from these two guys and channel it through the bundle of His. Look at it. See the bundle of His coming down. Then this is the left bundle of His. This is the right bundle of His. Now the bundle of His now gets to and become what? Subendocardial conducting what? Network. That's exactly how it spreads. And if anything happens to the electricity of the heart, we call it what? Cardiac arrest. All these atria, AFib, this one, that one, cardiac arrest. And it kills instantly. It kills you see somebody. That's why you should never fight anybody. I'm telling you, all these people. Yes, all these people that just go out and start fighting. I go on Instagram and I see people fighting. Jesus Christ, not me. I can never. Yeah, if you even punch me, I'll warn you, don't punch me again. And you punch me the second time, I'll collapse. I'm telling you, try it now. Collapse. And you'll be telling me to get up. I will not get up until you buy a Mercedes. That's the only thing that can get me up from that floor. Anyway, let's continue. Jesus. Now let's talk about the sympathetic nerve supply to the heart, right? The nerve supply, the nerve to the heart, we have the sympathetic nerves, right? What do? They increases the heart rate and contraction strength. Oh, now, action. If you start running, now maybe there's a snake wherever you are currently. Now, what will you do? You run, right? Your heart is starting boom, 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 boom. What do you think your heart is doing? Boom, 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 boom. You understand? Because of the sympathetic nerves. You understand? Because of the sympathetic nerves. And its origin is usually the cervical to the upper thoracic segments of the spinal cord. We already discussed this in neuro. So if you are wondering, this thing is too big, it's not true. We did it in AP1. You understand? Where does the sympathetic nerves come from? The sympathetic nerves come from where? They originate from the lower cervical to the upper thoracic segments of the spinal cord. You understand? And they continue to where? To sympathetic chain and ganglia, right? Then from there, they ascend the cervical ganglia. Hmm? After that cervical ganglia, you see what we call what postganglionic fibers. You understand? And where do they pass? They pass through the cardiac plexus. And they continued as what? Cardiac nerves. So this is showing you how it generates, right? How it generates from the lower cervical to the upper, you see, lower cervical to the upper thoracic segment of the spinal cord. From there to the sympathetic ganglia, right? From there to the post-sympathetic, become post-ganglionic fibers. From there, it enters the cardiac plexus. From there, it continues as what? Cardiac nerves to the heart. And that fiber, where does it stop? It terminates in what? The ACA node and the AV nodes. Extremely important that you know this. What about parasympathetic ganglia? The one that makes your heart slow down. You understand? It begins in the nuclei of the vagus nerve. We all know this thing. We discussed it in neuro. I shouldn't even be discussing it here. But for the benefit of people that we are not in AP1 with me, you should be able to look at this even after this class to understand it more, right? So the parasympathetic slows down, right? Anything parasympathetic is slowing down. You understand? And this semester we discussed the sympathetic and parasympathetic a lot. Like in parasympathetic, for example, there are some activities that are increased and some activities are reduced. One of those reduced activity is the heart. The heart is reduced. But things like the urinary system and the digestive system is increased. And if you remember when we discussed about parasympathetic and sympathetic, I told you that they are from the autonomic nervous system. If you cast your mind backwards, you guys are fortunate that I'm not in class. If not, I'll be pointing to some people right now to answer some of these questions. Because we discussed neuro very well, right? And I told you specifically that autonomic nervous system is divided into sympathetic and parasympathetic. And how is the autonomic nervous system formed? That's the question. What is autonomic nervous system? If you remember, I told you that we have sensory and we have motor. Sensory goes up to the CNS, motor comes back from the CNS. You understand? And if it's going to the skeletal system, it's what we call it what parietal, right? Mm-hmm. But if it's coming from the if it's coming or going to the viscerals, like the smooth muscle or the heart, you understand? It becomes what? Visceral. So autonomic nervous system is from the visceral motor. So the one coming backwards, you understand? Coming backwards to the heart and to the smooth muscles is visceral motor. And that visceral motor is what we call what? Autonomic nervous system. That autonomic nervous system is now divided into sympathetic and parasympathetic. And the fibers, this is the origination of the fibers. That's what I just explained to you right now. So we just discussed the sympathetic origin. And this is parasympathetic origin. Fibers usually from the vagus, right? Usually from the vagus. You understand? Then it extends to the cardiac plexus. Just exactly as this guy also, at the end of the day, look at it, at the end of the day, it extends to the cardiac plexus. This one also extends to the cardiac plexus. But parasympathetic is much shorter. All right? Fibers of the right vagus nerve lead to SA node. Fibers of the left vagus nerve lead to AV node. You understand? Fibers of right vagus lead to SA node, inhibition, slowing down SA node. Fibers of right vagus, which makes sense. But fibers of left vagus slows down what? The AV node. Remember this. You don't need to know too much. So let's discuss more about the other things, the electrical conductivity of the heart. All right? Extremely important that you know this. So we have a systole and we have diastole. Systole. From the side, from the sound, there's systole, squeeze, systole, contraction. Diastole is what? Die. Now, when something die, they are resting. Rest in peace. Diastole. And that reminds me, my father's burial is next month too. 5th. Anyway, that's besides the point. Diastole, relaxed. Diastole, relaxed. Dead. Diastole, relaxed. D for D. D for D. So you are in the clinic, they give you blood pressure. You know that the one up is big, is contraction, is strong, is heavy, squeezing. But the one down, diastole, dead. Down, diastole, dead. So that one down, that figure down is the diastole. And it is when it is the vessels are what? Relaxed. You understand? But guys, listen. When you're talking about diastole and systole, always think of the ventricle. Always think of the ventricle. What is the ventricle doing? Always think of what? When we say, oh, relaxation, oh, contraction. What is relaxing and what is contracting? Ventricle. Diastole, ventricle relaxing. Systole, ventricle contracting. It has nothing to do with the atrium or auricles. It has nothing to do with them. I hope I'm making sense. So there's something called sinus rhythm. Sinus rhythm is normal heartbeat. That normal heartbeat is triggered by the SA node. Guys, mind you, you are learning normal. You see, physiology, normal. Physiology, normal. You get? So, sinus rhythm is normal heartbeat triggered by what? SA node. For adults, 7 to 80 at rest. All right? At rest. There's something we call ectopic. Anything ectopic, like ectopic pregnancy, is as ectopic pregnancy is outside the uterus. Outside the uterus, right? Yes. Outside the womb. Now, what is it called? Ectopic focus is a region of spontaneous firing other than the SA node. Anything firing other than SA node is ectopic focus. Maybe sometimes SA node is damaged. There's something called nodal rhythm. If SA node is damaged, if the main wife is damaged, Tony, you pay for consultation. Oh, God. So if the SA node is damaged, guys, think about it. If the main wife finds out that the man has a side chick, what is she supposed to do? You know, the good thing that she's supposed to do. She will leave the guy, right? So SA node out. What SA node fires at 70 to 80. Now the man will pack himself and go and meet the AV node. But the AV node can never, that has a side chick, can never be like the wife. It can never happen. So what happens? The AV node will start firing at 40 to 50 BPM. You see? 40 to 50 what? BPM. Instead of what? 70 to 80 that the SA node was firing. So the heart rate is now start going down because it's with the side chick. And let me tell you something about the side chick. Before you know it, the side chicks are it can't walk. That's why the side chick can't walk. The man is busy looking for where to be and stay and who to be with. That's what we call what? Ectopic focal rhythms. Other ectopic focal rhythms. The side chick was even at 40 to 50, but those other ectopic focal rhythms will be like 20 to 40. 20 to 40. And at that time, we are begging the wife, the main wife, with using what? Defibrillator. Please now, please now. 1. Please now, please now. 2. Please now, please now. 3. So at that time that we are begging the main wife, if the main wife just say, okay, you know what? I will forgive you and accept the man back, the SA node will start working again. So the heart rate will jump back from this figure back to 70 to 80 BPM. But if the SA node, that's the main wife, refuses and say, you know what, no matter what you beg me in this life, I will never accept you back. What do you think will happen? This guy will move from this 20 to 40 to 0 and dead. That's why you see 1, 2, 3, boom, they will be looking at this thing. It will be reading the monitor. Person has died. But if they beg the SA node and the SA node agreed, the thing will just be doing immediately agree. Chicken. Everyone is there. You guys know what I'm talking about now. Okay, guys, that's fine. So the SA node does not have a stable resting potential, right? Doesn't have a stable resting. You know what resting potential is? Resting potential. Remember, all these things are cells, right? Like cardiomyocytes. Eh? All these things are cells. Inside the cells, you have the what? The negativity, which we discussed. For the heart, it starts at minus 60 MV and drifts upwards due to what? Slow sodium influx. All right. So if sodium starts entering, it starts becoming more negative. That's what we call what? Depolarization. And this is what pacemaker potential is about. When is the threshold? The threshold is minus 40 MV. All right. Immediately gets to minus 40 MV, fast gated calcium and sodium channels open. They jump into the cell. So immediately from minus 70, minus 40 MV, it jumps to 0. So the negativity increases very fast. So after that, potassium channel opens up and potassium starts leaving the cell. If potassium starts leaving the cell, what will happen? It will lead to what? Repolarization. So depolarization, repolarization. Just the same thing with skeletal muscle. So if you see why you need to understand these things, because you need to hold it in your fingertips. At the end of the day, after this class, you guys are going for pathology and others, right? You need this knowledge and pharmacology. If you don't know how do you know the medication to give your patient if your patient is dying? You see? How do you know which one will cause sodium influx? This is how you understand it. That's why you need to open your ear and know what sodium does and what potassium does, because that's also part of your exam. So SA node fires at 0.8 seconds. Every 0.8 seconds it fires. 0.8 seconds it fires. 0.8. Doom, 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 doom. Setting the resting rate at what? Resting heart rate at what? 75 BPM. All right. So you see what we discussed. This is the potential, right? Slow sodium enters and takes it to minus 40. Minus 40 is threshold. You need minus 40. Fast calcium and fast sodium enters and it's up. And when it gets up, that's depolarization. So the potassium starts leaving and brings it down. You understand? Potassium brings it down, then it goes up again. So the difference between here and here is what we call what? Pacemaker potential. And this is action potential. Pacemaker potential. Action potential. Pacemaker potential. Action potential. Pacemaker potential. Action potential. Somebody is laughing and say this boy is acting like a kid. Okay. Please, if you guys are tired and want break, tell me. But honestly, left for me alone, I know you are sitting down now, drinking coffee and smiling. Some people are pressing phone. That's fine. But better, I think we should just continue and get this over with so that you'll be able to prepare for your exams. Thumbs up if I should continue. Click the like button. You see the like button. Click it. Let me see how many we get to know if I should continue. One, two, three, four, five, six. Okay. So I think we are in order. Okay, guys. So let's continue. Let's get it over with. All right. Hmm. So this is just talking about how fast these things travel. All right. But we've already discussed the major phases. Yeah. So there are three phases to cardiomyocyte action potential. Now we are talking about the action potential. There are three phases for action potential. We have the depolarization, we have the plateau state, and we have the repolarization. Depolarization, very brief. Pium, you understand? Sodium gets closes very quickly. So stimulus opens voltage gated sodium channels in the membrane. Action potential peaks at plus 30 MV. All right. Sodium gets closes quickly. Plateau phase lasts 200 to 250 ms. This plateau phase is usually as a result of calcium. So what I need you to know is that the depolarization phase is usually by sodium, but the plateau phase is usually by calcium, and the repolarization phase is also by calcium and potassium. So calcium closes, potassium what opens. Repolarization. That's when it's dropping down. Calcium closes and potassium what opens up. Right. So rapid potassium going out of the cell, you understand, we cause repolarization. Just almost the same thing that we've been saying before. This question is, I don't know how to answer this your question. You say, are we finishing the PowerPoint? Of course now. Hey God. So please, I need you to understand this thing properly. So guys, look at it. Number one is talking about voltage gated sodium channels. All right. Pium is very fast. Pium. So sodium inflow depolarizing the membrane and triggers the opening of still more sodium channels, creating a positive feedback circle and a rapidly rising membrane potential. Look at it. Pium, sodium. Action potential, sodium. You get? Now, it starts plateauing. It drops a little, but it's plateauing. You understand? This plateau is as a result of what? Stopping here most times is as a result of what? Sodium channels. Sodium channels, all right? These sodium channels. Then it starts dropping down gradually as a result of what? Calcium channels. Stopping. Calcium stopping. So I need you to go back to this place and understand it very well. Depolarization, sodium channels, right? Depolarization, pium, sodium channels open, sodium flows inside, causing positivity. Do you understand? Then when it's getting up, voltage gated slow calcium channels open. Now, these slow gated calcium channels are still positive, but the only problem is that it slows down the amount of sodium entering. So that's exactly why, if in this diagram, everything is at a standstill here. Then sodium closes, calcium closes, and now potassium starts going out and everything starts dropping back. That is what we have here, repolarization. So calcium closes, sodium has already closed, potassium opens, and potassium is inside the cell, potassium is going out. So the cells start becoming negative again. Do you understand? I need you guys to understand it. If you don't have a question, you ask. All right. The cell start becoming negative again and it drops down. Down. So, like this number 5, they says calcium channels closes. We already discussed that. Calcium is transported out of the cell. We already discussed that. So the cells start becoming more negative, right? Then potassium channels open and rapid potassium flows out, returning the membrane to the potential. Pium down. So what you need to know is which one is opening and which one is closing. That's what you just need to know. So sodium is opening here. Pium. At this point, sodium is closing. Calcium opens, but calcium is slow. Suddenly calcium closes and potassium opens and everything goes back to default setting. That's exactly what we have here. So this is the electrical behavior of the myocardium. All right. So if you still have a concern with it, you can ask question, or later you go back to the slide and slow me down. All right. I'm jumping these things because these are not my diagrams. You can look it up. They will help you, but they are not really the diagrams I use. So we have the electrocardiogram, the ECG or the EKG, right? Very, very important because we use it to detect a lot of things, right? It has different electrodes in the arms, legs, and chest. We use to detect the normal electric activity in the heart. And this is the normal electric activity in the heart. This is it. All right, the P wave, the T wave, the QRS complex, the PQ segment, the ST segment, the QRS interval, and the QT segment interval, and the PR interval. All right, so you need to understand the segments, the waves. You understand the segments, the waves, the intervals. There are the three major things you need to understand: the segment, the waves, the intervals. All right. As you move on in class, you understand very much how to read this thing. It's one of the easiest things you can ever understand if you know the formula. Okay, so let's just discuss about some parameters in it, right? So we have the P wave, the P wave. This is the P wave here. This is the P wave here. Pium, pium. You see the wave? Pium, pium. This is the wave. But from the beginning of the wave to after the ending of the wave to this part is known as what? PR interval. PR. This is R. Pium, PR interval. But this elevation here is known as what? P wave. So if you do somebody ECG, right, and this P wave is upside down, you will know that something is wrong, correct? So that's why you need to know how the normal looks. Do you understand? For example, if you measure somebody's QRS complex, two opposite QRS, two adjacent QRS complex. This is a QRS complex, this is a QRS complex, and this is 0.8 seconds. And you measure it and it's maybe like 0.10 seconds. It means it's very slow. Or 0.20 seconds. It means it's 20 seconds. It means that it's very slow. That something is wrong. Do you understand? So the most important thing is we want you to know the normal. So you need to look at this diagram. Look at it very well. Now, what is happening in the P wave? This thing that happening in P wave is called what? Atrial contraction. So this P wave happens when there is a contraction of the atrium. This is atrial contraction. So if I look at your P wave and it is not as it should be, I will know that something is wrong with your atrium. Look at this place. This is the QRS complex, right? The QRS complex. This is the interval, the QT interval. And this is, you see this wave. Pium, 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 and this place. So if I check this wave and it's not like this, sometimes this wave is inverted. If it is not like this, I will know that there's something wrong with what? Ventricular contraction, because all these places signify ventricular what? Contraction. So this is atrial contraction, this is ventricular contraction. So if I connect this electrocardiogram in your body now and your atrium contracts, I will see this. If your ventricle contracts, I will see this. And the cycle continues. So I need you guys to understand it. I need you guys to, appreciate it. You may not understand it, but I need you to appreciate it. All right? So P wave, that is where SA node fires, atrial depolarization and contracts. Atrial systole begins 100 meter per second after SS signal. All right? That's normal. Then this is the QRS complex. That's ventricular repolarization. P wave, atrial depolarization. QRS complex, ventricular depolarization. P wave, atrial depolarization. QRS, ventricular depolarization. In your exam, they will tell you QRS complex signifies what? You tell them QRS complex signifies what? Ventricular depolarization, not atria. Anything atria is on the P wave side. Remember that. All right. Then the ST segment is ventricular systole. It corresponds to the plateau in myocardial action potential. So this is the ST segment. This is ST. This is ST segment. ST segment. You see, this is ST segment. So here to here. This is ST segment. Huh? You see? So you see exactly what we are talking about. The ST segment corresponds to what? The plateau. This is the plateau we are talking about. If I go all the way back, this is the plateau we are talking about. That's what the ST segment signifies. All right. So if the ST segment is wider than normal, then there is a problem. You will start thinking, what causes it? There will become a problem. Then this is T wave. T wave is what? Ventricular repolarization and relaxation. Here is T wave. This is T wave. Ventricular what? Repolarization and what? Relaxation. That's T wave. You must know what each of these waves stands for. What this complex stands for. What this segment stands for. For your exam purposes. All right? This is the diagram. Take a very good look at it. And it's exactly what we already explained here. All right. Okay. So this is myocardial infarction. Things that could cause the ECG to be abnormal. All right. It can be myocardial infarction. It can be a blockage, activity in the conduction pathway. Maybe there's right bundle branch block and all those things. It can be enlargement of the heart, cardiomegaly. It can be electrolyte and hormone imbalances. Anything could make it abnormal. So we use ECG to actually pinpoint some diseases or some problems in the heart. Extremely important. All right. So this is normal sinus reading. This is normal. This is ventricular fibrillation. This is normal sinus reading. This is how normal is. So look at it. You see how clean it is. You see how the distance between here and here equal. Here and here equal. Here and here equal. This wave and this wave, the distance is equal to the distance with this wave to the distance with this wave. If it is not like that, then there is a problem. Look at it. Don't you see this is a problem? Something is wrong. All right. So that's ventricular fibrillation. Anything could lead to ventricular fibrillation. All right. It can be arrhythmia. Arrhythmia kills people very fast. All right. When the electrical activity is moving randomly, no perfusion, no pump, nothing. And it's usually as a result of myocardial infarction, because that particular part of the heart cannot no longer work. And it kills very fast if it's not stopped. So what do? We start giving you shock, electricity. Do you understand? That's what we call defibrillation. Strong electrical shock with the intent to depolarize entire myocardium. We are doing reset, factory resets. Like when your phone is hanging, what do? You try to reset it. Is it a cure? No. But is it to save life? Yes. So when you save that life, then we now start checking what could have led to that. What could have annoyed the main wife? Okay. It must not be the main wife. It can be anybody. This is heart block. This is premature ventricular contraction. You see, if you look in premature ventricular contraction, what happens? Don't you see? This is normal. This is normal. And you see, this QRS complex goes down. So you see a QRS complex going down after some normal complexes, and others continue normal. We call it premature ventriculation. This is where the premature ventriculation works. Then you are not looking. Why does this person have premature ventriculation? Do you understand? Look at this heart block, for example. This person's heart is blocked. Why? Because there is no QRS complex. You understand? There's no ventricular depolarization. Doesn't happen. Look, you are seeing P wave here. You see P wave. You see P wave. You see P wave. Then there's a problem. So when you see multiple P waves like this, you're talking about heart block. Heart has blocked somewhere. But this guy is premature ventriculation because it's affecting the ST segments. All right? I'm just showing you little things. This thing won't make you learn ECG properly, but to make you have, have the idea of what we are talking about when we are talking about ECG. Extremely important. All right? So we are really moving very fast. Let's talk about the flow, right? How does pressure affect blood flow? How are heart sounds produced? We talk about cardiac cycle. You understand? When you talk about cardiac cycle, you're talking about one complete contraction and relaxation of all four chambers of the heart. All right? So the major things you need to know is how the fluid flow. You understand? Because fluid can only flow if there is a pressure gradient. There's no two ways about it. If there's no pressure gradient, fluid will just remain there. You understand? So fluid flows from higher pressure points to where lower pressure points. Higher pressure points to where lower pressure point. And what do we measure it with? Sphygmomanometer. Initially, I called this thing sphygmomanometer. But it was later I know that it's sphygmomanometer. I can guess that some of you don't know the pronunciation. Right? So this is principles of pressure, right? Pressure gradients, events occurring on the left side of the heart. You understand? So taking the left side of the heart as a case study, when the ventricle relaxes and expands, its internal pressure falls, which we already discussed. Remember, everything we are talking about is ventricle. When it relaxes, the heart relaxes. When ventricle relaxes and expands, its internal pressure falls. Relaxation causes expansion, right? So if mitral valve is open, blood flows into the left ventricle. You guys remember where mitral valve is? Immediately they say it, you should picture it in my mind that mitral valve is what? Bicuspid valve. And it is an example of what? AV valve. And another name for mitral valve is what? Left AV valve. These are information you should know in your fingertips. All right? Sure, this phone. So, when ventricle contracts, internal pressure what? Rises. Right? AV valves closes. Why? Because it's contracting to push out blood through the semilunar valves. At that moment, the semilunar valves open. So that's why you see, look at it very well. AV valves closes. The aortic valve is what? Pushed open. Why do we mention aortic? Because we are talking about the left side of the heart. So what happens in the left side of the heart? Right? When the ventricle relaxes, right? The mitral valve opens and fills the ventricle. Then the mitral valve closes and the ventricle has to push out that blood. Through where? Through this valve, the aortic valve, into the aorta. If it's the right, what happens? You guys already know. If it's the right, what happens? The tricuspid valve opens up and pours blood. At that moment, the ventricle, the right ventricle is what? Relaxed and it expands. Take a lot of blood. Then the tricuspid covers up, right? Then the pulmonary valve opens up and it pushes the blood to the lungs. That's what happens in the right. And this is what happens in the left. My leg is hot. They said I should be icing. Yeah. So opening and closing of the valves are governed by pressures, all right? So you need to remember this. We already discussed this thing. Yeah, I understand. So do you remember when I told you initially that all those structures we discussed in the body can have a problem? So when the valve has a problem, we call it what? Valvular insufficiency or valvular incompetence. Even your valves in the leg can have a problem. And if the valves in the leg have a problem, it leads to the valves of the vein in the leg. What does it? Varicosity. You know varicosity now, varicose vein. It's always because of valves in the leg. And there will now be, backflow of blood, downflow of blood. Vein takes blood upwards. There will now be downflow of blood, leading to what? That engorgement you see. That's varicosity. That's exactly what happens in the heart. So here, valvular insufficiency, we call it what? Valvular incompetence, right? And what is valvular incompetence? It's just, failure of a valve to prevent reflux or regurgitation or backflow. It's just like your esophagus. The lower part of the esophagus has a sphincter, right? We call it sphincter, because it's an organ, we call it sphincter. What does that sphincter do? When you eat food, that sphincter closes so that food doesn't back up. Which is what I was explaining to you that time. Because I have diabetes, did I say diabetes? Let me clean my mouth. Because I have dairy allergy. Lactose intolerance. That's what I was thinking. Oh, Jesus. Because I'm old. I'm getting old. I'm 49 years. Okay. Because of that allergy, those my, the esophagus, the sphincter will not work. What happens? There will be backflow of food. That can lead to vomiting. That can even lead to aspiration. That's why when somebody has, like the surgery I had the other day, it was GA. So they told me I didn't eat from 8 p.m. the day before to make sure that there's nothing in my stomach. All right? Because when you are under anesthesia paralyzes virtually all organs in your body, all muscles in your body. And some of those muscles is what? The sphincter. That's sphincter, lower esophageal sphincter. Right? So if it paralyzes, what does it mean? If there's something in your stomach, it can go up, can regurgitate up. And when it's going up, it may not come out from your mouth. Instead, it will enter the lungs. Just go through the laryngopharynx, enter the lungs. And at that moment, you cannot fight it. You can't cough. Coughing, it takes muscle to cough. You can't cough. You can't fight it. And the person will just die. You understand? There has been cases. So when they tell you in the clinic, don't eat, please don't eat. Like they told me, don't eat, don't drink water, don't even chew gum. So reflux is not good. All right. So if there's a valvular failure, because valves helps to stop blood going backwards. You understand? So what are some things that can cause valvular failure, insufficiency? One of them is valvular stenosis. Stenosis is when the valves are stiff. Stiff. You understand? So they can't, contract and expand. They are stiff. That's what we call what? Stenosis, valvular stenosis. Usually caused by what? Scar formation. Maybe there's an injury. You understand? What could cause valvular stenosis? Things like rheumatic fever, autoimmune attack on the valves, mitral and aortic valves. Or maybe your heart is overworking itself, and because of that, the heart becomes too enlarged, cardiomegaly. Do you understand? And this still leads to murmur. You understand? How do we know? Murmur, because there's abnormal sounds produced by what? That regurgitating blood. Normally, it's supposed to be loop doop, loop doop, loop doop. But because something is regurgitating, it will not be loop doop, loop doop, loop doop, loop doop, loop doop. Do you understand? That other sound, it becomes a problem. Murmur. All right? Because of incompetent valves. Okay. Another thing that could be a problem, like here we talked about stenosis. Another thing that could be a problem is what? Prolapse. Prolapse is when the valve, drops like this. Prolapse. You understand? So insufficiency in which one or both mitral valves bulge into the atrium. So sometimes it can prolapse or it can prolapse backwards into the atrium, right? During ventricular contraction. You understand? Sometimes it's heredity. 1 out of 40 people have it, right? It causes chest pain and shortness of breath. And it causes shortness of breath, of course. You understand? Because things are going back where they are not supposed to go back. Do you understand? And these are heart sounds. How do we hear heart sounds? Auscultation. All right? We have the first heart sound, we have the second, we have the third, we even have the fourth. The third ones are always very rare. You understand? Especially when people are over 30 years, very, very rare. But the first heart sound is a lop, and which is what you'll be asking in your exam. The second heart sound is what? The dop. Softer and sharper. Lop dop, lop dop, lop dop, lop dop, lop dop. The question you need to answer yourself right now, what you need to put in your fingers is what causes the first heart sound and what causes the second heart sound? S1. What causes S1? Because they will ask you your question. No, I'm telling you now, this is review. Somebody say review now. This is review now. First heart sound, lop, occurs with closure of AV valves. What leads to closure of AV valves? When AV valve closes, what happens? Contraction. It closes. Semilunar valves open. The ventricles contract and pushes blood out to the lungs and also to the aorta. And that's what causes first heart sound. First heart sound is that AV valve closing, pam, so that contraction will happen. So that first heart sound works with systole. Remember, we said contraction is systole. This is what you need to know, the information you need to know, because they can answer your exam. Lop, which is the first heart sound. First of all, you need to know that lop is the first heart sound. What is his relationship with the valves? You tell them that the AV valves is closed. And you tell them that the SA valves is open. You tell them that there's contraction in the ventricles. Of course, what we are talking about is ventricles. And you tell them that it occurs during what? Systole. What about the second heart sound, the dop? Opposite. So when the pulse blood, this guy has to close the SA node. Sorry, the semilunar valves. That's the aortic valve and the pulmonary valve. They have to close. And for them to close, this guy up will open. So immediately close, backham. This one up opens. That's the AV valves open. And the blood from the atrium start pouring into the ventricle. What happens to the ventricle? It will relax. So relaxation. Remember we said dead. Diastole. Relaxation, diastole happens with what? S2. So S2 is closure of the semilunar valves. What are the semilunar valves? We talk about what? The aortic valve and what? The pulmonary valves. These are the two semilunar valves. When they close, that is what? The lop. But when the AV valves close, that is the tricuspid and the mitral. When they close, that is what? The lop. Then the dop is the semilunar valve. So you need to understand this. Please, if somebody did not understand, type it there. Emergency, I'll go back. Should I continue? If I should continue, type continue in the chat. Chat, type continue. Let 10 people type continue. Let me continue. Because I need to. One, two, three, four. And we are 20 something people here. Come on, guys. One, two, three, four, five, six. Are you sure it's not time to take the attendance? Let me see. Maybe it's time I should take this attendance since people are not here. Since people are not here. Because why will more than 2 minutes and they're not talking? What's making that noise? Trying to open this shit. 18. One, two, three, four, five, 6, 7, 8, 9, 10, 11. Okay. Somebody's just waking up. Okay, guys. So phases of cardiac cell, you must know these phases and what happens in these phases. We have the ventricular filling. Ventricles fill up. Think about, guys, I really need you to think right now. Forget whatever, please. Keep your phone. I'm seeing somebody with, why are you pressing I'm seeing somebody with your phone. Don't press phone. Okay. So ventricular filling. Think about it. For ventricle to fill, for you to fill up something, it means that you have to close the below the stuff and open the above. What is above? AV valves. What is below? Semilunar valves. So it means that ventricular filling that happens when semilunar valves are open. Sorry, when AV valves are open and semilunar valves are closed. I need you to drive it, wisdom. I need you to drive it. Don't just know, oh, ventricular filling. You can't start reading what is ventricular. No, you need to know what is happening in ventricular filling. That means that you were in this class. You don't need to, after this long lecture, go and start reading slide again. No, I need you to go and start solving questions. Maybe I will also look for the live session I've had here and post it for you guys. So, but ventricular filling is usually It usually happens, you know, it's open, the above is open. And what is above? AV. Automatically, you know that the AV valves are what? Open. So it's filling. So the blood is coming from atrium. The ventricle is relaxed. That's why we say ventricular filling during what? Diastole. It's relaxed, it's dead. Diastole, D for D. Now we have what something we call isovolumetric contraction. Anything contraction should happen when? During systole. At that moment, the AV is closed, the semiluna is open. It presses out, pium, and it's pressing out equal volume of fluid from both the right and the left ventricle. That's why we call it what? Isovolumetric contraction. But when it's relaxing, exactly, the two of them are relaxing the same ratio, the same equal. Blood is entering through them, through the atrium into them. That's isovolumetric what? Relaxation. And anything relaxation is what? Diastole. Ventricular filling, diastole. Isovolumetric relaxation, diastole. But when you talk about systole, you talk about pressing, ejection, ventricular ejection, pressing. Because it has to press for the water to run out. I finished my water. I should have shown you guys. You see? See? Boom. Press it and water comes out. Press it and water. Means that the one below it is what? Open. Which one is below it? Semilunar. Which one above it? AV. So this one has to close and it will press. Then it will now shut off. Pium, and open up. And water start entering. Pium, here. And it will start relaxing. That's diastole. You need to know the difference between diastole and systole. If you understand it, we are good to go. And this entire cycle, you know, all the 4 phases, right, are completed in less than 1 second. What are the 4 phases? Filling and pushing out. Filling, we call it ventricular filling, of course. And ventricular what? Pushing out, relaxation, and ventricular ejection, rather. Filling, pushing out. Filling, pushing out. And it fills equally. That's isovolumetric. Rather, it pushes out equally. That's isovolumetric pushing out. You know what pushing out? Like when you some of you are ladies, you already have babies. You know how you were pushing. They say, push, contraction. You are trying to push out that baby. Exactly. So you should think about it. You understand? But when you relax, everything widens out and you accept. Any question, guys? So this one explains everything. Like I really don't want to waste time explaining all these things, but go look at it later. But it explains everything that you need to know. Everything I just explained is that what happens. Okay, let's take a case study. Ventricular filling. Ventricles expand and their pressure drops below that of the atrium. Of course, filling has to open up, right? At that moment, what opens? AV valves open. What closes? Semilunar valves closes. What opens? AV valves opens. That's the up one. So it has to open for it to fail from the atrium. Remember, atrium is up. It keeps filling. At that moment, P waves occurs. Okay, perfect. You understand what I'm talking about. Thank you so much. You understand? Okay, so this volumetric contraction. You understand? Remember, it's causes this contraction happens, causes depolarization, which causes a QRS complex. So you need to know volumetric contraction leads to depolarization, which causes QRS what? Complex. Extremely important. And what is closed? The AV valves are closed, up. And what is open? The semilunar valves are what? Open. Which heart sound? S1 occurs. Why is S1 occurring? Because the up one is what? Closed. Bam, you see my hand? Loop. After all, it comes first before the semilunar valves. Do you understand? The AV valves comes first before the semilunar valves. So that's why it's 1. So always remember. Loop, AV valves. Loop, AV valves. Loop, AV valves. Loop, AV valves. Contraction happens. This one closes. Doop. Relaxation happens. Then this is ejection. All right. This is ejection. All right. That's when you start talking about stroke volume, right? Ejection fraction. Stroke volume is around 70 ml. Right? We're going to discuss these things very, very well. So sometimes ejection can be reduced. There's something called reduced ejection. Slower flow with lower pressure. You understand? That's why you see somebody heart failure with reduced ejection fraction. All right. So ejection fraction is about 54% of the EDV. EDV is about 130 mils. That's the end diastolic volume. end diastolic volume. What is diastole? When it relaxes. So when in the complete relaxation, how many amount of fluid fills the ventricle? 130 mils. That's EDV, end diastolic volume, right? And how many does the heart push out? The heart will end up pushing out 54% of this end diastolic volume. And that's what we call ejection fraction. So ejection fraction is about 54% of end diastolic volume. This is for normal. So if somebody's ejection fraction is very low, you know that that person is having a lot of blood packed back in the heart. That's serious heart failure. So how many mils are remaining? 60 mils. 60 mil remaining blood is end systolic what? Volume. End systolic volume. So how do we know end diastolic volume? Stroke volume is the amount of fluid that's pushed out, right? That's stroke volume, right? That's 70 ml. But the entire amount of fluid is 130 ml. So if you remove, and 54%, which is this stroke volume, right? So if you remove 70 ml, which is 55%, if you remove 70 ml from 130, how many is remaining? 60 ml. And this remaining one is what we call end systolic volume. So if they give you a question, for example, and tell you, 60 mils is remaining, you know, what is end systolic volume? Tell them end systolic volume is what? 60 mils, because that's what's remaining. At the end of systole is pushing out. At the end of systole, how many is remaining? 60 mils. That's end systolic. At the end of diastole, when it's getting everything, how many is remaining? 130. 130, end diastolic. At the end of systole, pushing out, how many is remaining? 60 mils. So if you want to get what is pushed out, what do? You put the end diastolic volume. Do you understand? If you want to get what is pushed out, you can minus this from this, and you get this the stroke volume. That's end diastolic volume minus end systolic volume. You get the stroke volume. So you can just do permutation and combination. If they ask you to get ESV, end systolic volume, what do? End diastolic volume minus systolic volume. Simple. So if you minus end diastolic volume minus end systolic volume, you get stroke volume. If you minus end diastolic volume minus stroke volume, you get what? ESV. And if you want to get end diastolic volume, just add the end systolic volume and the systolic and the stroke volume. Chicken, and you're good to go. So just do permutation and combination. But the most important thing is that you need to understand the concept. It's all about concept, guys. You need to know, how many is ejected, how many is reduced, so that when you calculate somebody's ejection fraction and the fraction you understand that is ejecting is too low, then you know that there is a lot of blood remaining in the heart. It becomes a problem. Okay, these are the same thing. We've already discussed this thing. Total duration of cardiac cycle is 0.8 second in heartbeats, beating 75 BMP. So BPM rather, beats per minute. So you must know that the cardiac cycle is 0.8 second. If they ask you, this is your exam question probably. How do we arrive to this 0.8 seconds? Because the arterial systole lasts 0.1. The ventricular systole lasts 0.3. How many? 0.4, right? There's something that the quiescent period when all four chambers are in diastole lasts 0.4 seconds. So if you calculate it, the entire cycle is what? 0.8 seconds. And what is the beat? 75 beats per minute. Record it in your head right now. Record it in your head. This is Wigger's diagram. Please look at it at your leisure. Everything we discuss is what is here. The end diastolic volume, the end systolic volume. You understand the valvular opening, where the valve opens, where it doesn't open. Everything is in one diagram. So this diagram should be your wallpaper if you really want to understand this thing. All right. So this is just giving you the normal values for these things. Look it up later. So overview of volume changes. Normally, right and left sides of the heart eject the same volume of blood, even though they are under different pressures. All right. But there's something we call congestive heart failure, right? The congestive should tell you that it is because the heart is not able to pump out blood. So it's, it's now too much blood is now remaining. You understand? The ESV, all right? That end systolic volume is too much. You understand? So it's leading to what? Congestion. You understand? And what can cause that congestion? What can make your heart not to be able to pump out the normal amount of blood it should pump? A weakened heart, infarction. Maybe the person is having myocardial infarction, chronic hypertension, valvular insufficiency, or congenital defects. So if somebody has any of these, you understand, then know that the person is a candidate for congestive heart failure now or in the future. All right. So any part of the heart can fail. So we have left ventricular failure and right ventricular failure. Left ventricular failure usually when blood backs up into the lungs. That's left ventricular failure. Think about it. How does blood come to the left part of the heart? If you are going backwards, you say from the left ventricle back to the what? To the left atrium. Back to what? The pulmonary vein. Back to what? The lungs. You see? So if there is backup of blood, it's going into the lungs. And if fluid is getting into your lungs, if you are drinking water and small little water droplet enters your lung, what do? You start choking and coughing, correct? Now imagine a whole lot of fluid, that is water, blood, going back into the heart. That is failure. You understand? What happens to that patient? The patient starts suffocating. Have you guys seen the patients with heart failure? They start having this breathing. You understand? See what I'm saying? I'm already having a headache. Oh, Jesus. Okay, guys. Well, let's round up. We have very few minutes to go, right? Why is she laughing? Okay, so that's left ventricular failure, all right? So you should know the how it happens, so that when in the clinic you see somebody having a sense of suffocation, trying to breathe, and all those, this person had left ventricular failure, probably. Now, how do we know right ventricular failure? Right ventricular failure, the blood does not go to the lungs. So you are breathing fine. The patient is breathing fine. But you see, right heart, blood going backwards is going back to the largest vein. That's vena cava, right? Blood will start going back to the vena cava. Now, what does it lead to? Blood going backwards. Going backwards. You understand? There's something. It will lead to what? Pulling off a lot of fluid in your body. That is what we call what? Edema. So right ventricular failure always leads to what? Edema. But left ventricular failure leads to what? Breath shortness, because it goes to the lungs. But edema, because the fluid goes back to the systemic circulation. You need to understand this thing. If you understand it, trust me, you will never forget. If they wake you up like this and tell you right heart failure, you tell them, right heart failure is usually when this thing goes back into the lungs. Oh, what will it lead to? You don't need to think. Anything that goes back to the lungs will cause suffocation and shortness of breath. Simple. Oh, that's left heart failure, sorry. And when they ask you right heart failure, you say, it's going back to the vena cava, right? If it goes back to the vena cava, what happens? There will be pulling of blood everywhere, leading to what? Edema. So it causes generalized or systemic what? Edema. And what can lead to right heart failure? Things like what? Liver problem, ascites, pulling of fluid in the abdominal cavity, distension, jugular veins, swelling. You understand? All these things will become enlarged because of right heart failure, all right? Sometimes it eventually leads to a total heart failure. That's when the two of them combines to mess up the individual, all right? So there's necessity for everything to be balanced. This is just talking about the input and the output. Okay, so let's talk about the cardiac output quickly before we round up. You understand? The cardiac output is just the amount ejected by each ventricle in 1 minute. 1 minute. Cardiac output. Another formula for cardiac output is the amount of fluid that is pushed out by heart rate. You see, rate, minutes, rate, minutes. The amount of fluid, liters. You see? Liters. So that's why the measurement is what? L per M. Minutes. Liters per minute. Do you understand the calculation? So this is the amount of fluid that just flows out after diastole, after systole. The amount of fluid that flows out. So when we calculate that amount of fluid that flows out per minute, it becomes what? Cardiac output. All right? And when it leaves, it has to come back to the heart. You understand? in about 1 minute. Okay, that's by the way. So vigorous exercises, CO is about 21 liters per minute, a lot in 1 minute, because you are doing vigorous exercise. Your body needs more fluid. But normally, you need to know the normal, which is 4 to 6 liters per minute when you are at rest. Like right now, all of you are at rest. You understand? Cardiac reserve, the difference between person's maximum and resting CO. You understand? Depends on fitness and reduce diseases. So when you're talking about heart rate or pulse rates, let's talk about pulse. Pulse is the surge of pressure produced by the heartbeat that can be felt by palpating a superficial artery. That's pulse. You understand? Now, these are the normals that you need to know. Infants have heart rate of 120 BPM or more. Young adults, females, average 72 to 80 BPM. Young adult males, 64 to 72. Females has more than males. Are you serious? 70 to 80. Young adults. Honestly, I'm seeing this for the first time. So children and elderly are the same thing. You understand? When you are a child, your heart rate increases. When you are elderly, your heart rate increases because things are no longer how it used to be. So there's something called tachycardia. Tachycardia is when the resting heart rate is above 100 BPM. It can be as a result of drug, when you take drug that you're not supposed to take, or stress, or heart disease, or anxiety. They break your heart. Your heart starts or stress. Or it can lead to loss of blood or damage to myocardium. Myocardium can be damaged. When you talk about bradycardia, that is when it's less than 60. So 60 to 100 should be around the normal. So when it's less than 60, it becomes bradycardia. When you more than 100, it becomes what? Tachycardia. Bradycardia, sometimes when somebody's sleeping, temperature is so cold, like today. I don't know why the temperature is suddenly so cold, but I like it. Honestly, I like it because I was so sick 2 days ago and 3 days ago and yesterday because it was hot. Until in the night when it became very cold. I was so happy. Okay, so you knowing these things will teach you what we mean by positive chronotropic. Anything positive chronotropic is something that increases heart rate. So if I give you a medication that increases your heart rate, we say that medication is what? Positive what? Chronotropic medication. If I give you the one that lowers heart rate, we say it's negative chronotropic. So let's talk about chronotropic effects. Chronotropic effects. So autonomic nervous system, does not initiate heartbeats, but instead it modulates the rhythm and force. You need to know that. Heartbeat is initiated by what? By the SA node, the pacemaker. All right. So cardiac centers in the reticular formation of the medulla oblongata initiate what? Autonomic what? Output to the heart. How does it goes to the heart? How does the nerves go to the heart? It starts from the medulla oblongata. So there's something we call cardiostimulatory effects, and there's something we call cardioinhibitory what effects. When you talk about cardiostimulatory, it's something that stimulates. So there are some neurons from that medulla oblongata, which is the center, all right, or the cardiac centers in the reticular formation, right? There are some neurons in them, right, that transmit signals to the heart by way of sympathetic pathway. So which makes sense. Once it transmits through sympathetic pathway, the heart will start beating faster. But when it transmits it through the things like parasympathetic pathway, like the vagus nerve, it starts beating what? Slower. So the vagus nerve is parasympathetic. Remember it. Vagus nerve, parasympathetic. Cardioinhibitory. You understand the point? Sympathetic pathways, what? Cardio, what? Stimulatory. You must always remember this. We've discussed it initially. Now, let's discuss more about sympathetic. We discussed this in the neuro, but we are shedding a little light on it. I discussed it in special senses for people that don't know when we discuss about preganglionic and postganglionic fibers. All right. Now, here we are being very specific. The autonomic nervous system. Sympathetic postganglionic fibers are adrenergic. Why do they say they are adrenergic? Sympathetic postganglionic. Usually, the preganglionic and of the sympathetic and also the preganglionic and the postganglionic of the parasympathetic are usually cholinergic. But sympathetic postganglionic is adrenergic. It releases what? Adrenaline. Things like what? Norepinephrine. We also call them what? Catecholamines. All right? And what do? They bind the adrenergic fibers of the heart, specifically the beta adrenergic fibers of the heart. Remember, I told you we have the alpha, we have the beta. We even have gamma. But they are specific about the beta adrenergic fibers in the heart. And when they activate these beta adrenergic fibers in the heart, what happens? That leads to activation of the second messenger in the heart. And what is second messenger? Always, I told you, CAMP. All right? Second messenger, CAMP. It is that second messenger that leads to opening of calcium channels in the plasma membrane. Extremely important. Extremely important. So when the calcium channel is open, there's increased calcium inflow. That increased calcium inflow will accelerate the depolarization of what? The SA node. Very, very important that you understand this. You understand? Then from there, the second messenger keep encouraging the calcium to continue to be uptake by the sarcoplasmic reticulum so that we have more calcium. Extremely important by this. Extremely, very, very important. So I need you guys to take time and look at this. You don't need to look too much in it, right? But you need to just understand about the sympathetic preganglionic and sympathetic postganglionic of the autonomic nervous system. If you understand it, and you should understand that it releases through what? Norepinephrine. Those are the most important things. And you should understand that it activates its fiber. What fiber is it? A beta adrenergic. In the exam, they may tell you the fibers, alpha, beta, gamma. Please, it's beta adrenergic. And what does that beta adrenergic do? It activates what? CAMP, which is second messenger. And what does second messenger do? Opening of calcium channels, and you are good to go. All right? You are good to go. So whenever you inject somebody EpiPen, you know EpiPen, epinephrine, you should know what you are doing to that patient. What did I tell you about postganglion, parasympathetic? I told you that it uses the vagus nerve. And its fibers are what? Cholinergic. Usually for the heart, it is cholinergic inhibitory. But for the muscle, it is cholinergic what? Excitatory. That's why if cholinergic goes to the heart, if the cholinergic goes to the muscle, it excites the muscle. You understand? Your contraction is by cholinergic effects. You understand? You guys remember muscles very, very well. Acetylcholine. But acetylcholine in the heart inhibits the heart. That's what I need you to know. Acetylcholine in the heart inhibits the heart. But that same acetylcholine in your muscle, it activates the muscles. So what does acetylcholine do? It binds to muscarinic receptors, and muscarinic receptors will lead to opening of the what? Potassium channel in the nodal cells. And when potassium, what will happen to potassium? Potassium will start going out, leading to what? Hyperpolarization. That is, the heart will what? Slow down. So what do you learn? Learn that parasympathetic slows down the heart. How does it work? Vagus nerve. Using what? Cholinergic fibers. Cholinergic fibers produces which neurotransmitter? Acetylcholine. What does acetylcholine do? Opens the potassium gates, and potassium gates start leaving, leading to more negativity, leading to slowing of the heart. Remember this thing. You see the way I mentioned it, the way I organized it? That's how you need to remember it. All right. Okay. So this is just talking about the cardiac centers, right? Like the higher brain centers, like cerebral cortex, limbic system, hypothalamus. All of them, all these things joins hands to, activate the autonomic nervous system. Very, very important. So here they discuss it one after the other, like in the medulla. Medulla receives inputs from the muscles, joints, arteries, and brainstem, right? Proprioceptors, very, very important. Proprioceptors in the muscles and joints inform the cardiac centers about changes in activity. You understand? So if you start running, your proprioceptors will go and tell the brainstem that, oh, this guy is running, and immediately the brainstem will go and tell the heart to what? Increase its rates. That's why when you are running, it sense it and tell the heart to increase rates. You understand that there's a lot of metabolic demand. You need oxygen. You understand? So the heart will now start pumping and pump a whole lot of blood for you to, be able to run, for you to be able to do that exercise. So that's how it works. All right. Then we have baroreceptors. Baroreceptors just measures the pressures, blood pressure. Oh, your pressure decreases. Why did it decrease? It tells the heart increases the pressure. So these are how it works. All right. Then we have chemoreceptors. We already discussed these things. Chemoreceptors, sensitive to chemicals, pH, CO2, oxygen level. All right. So these are talking about transmitters. We've already discussed transmitters like norepinephrine and acetylcholine. Norepinephrine, acetylcholine. All right. Like there are some things in your body that it stimulates catecholamines, like nicotine. That's why when you smoke something that has nicotine, you become hyperactive. And when you become hyperactive, you are becoming hyperactive because it's stimulating your catecholamine. And what does catecholamine do? Catecholamine will go to the heart and cause it to start beating very hard. That's not epinephrine. So you need to remember. Same thing with caffeine. You understand? Caffeine breaks down CAMP. You understand? It inhibits CAMP breakdown. Remember, CAMP is what. Do you guys remember what we mentioned here? I'm going back. What did we mention here? We mentioned that this CAMP leads to opening of calcium-gated channels. And what do calcium-gated channels do? If it leads to opening of calcium-gated channels, it will lead to what? Depolarization. Your heart will continue beating faster. Do you understand? So if I give somebody something to inhibit CAMP, you understand? To inhibit CAMP, what will happen? That's what this place is talking about. Look at it here, guys. So caffeine inhibits this CAMP breakdown. If I give you something that will not make your CAMP break down, because if your CAMP breaks down, you will not be able to take up calcium. When CAMP is there, you are taking a lot of calcium. Your heart is beating fast. Do you understand? So when CAMP breaks down, you can't take calcium, so your heart slows down. Now, I give you caffeine. What does caffeine do? Caffeine will protect CAMP. So there will be more CAMP in your body. And that more CAMP will lead to what? More calcium uptake, leading to more adrenergic effect. Your heart will keep pushing in. I need you guys to understand, what does nicotine do to stimulate catecholamine? What does caffeine do when you drink coffee? Why is it making you awake? Why is it making you active? Me, it doesn't make me awake. It makes me sleep. Who does coffee make sleep here? Anybody? Who does coffee make sleep here? Nobody. Ah, okay. I have a partner in crime. Yes, I have a partner in crime. Thank you. So these are chronotropic chemicals, electrolytes. Yes, like potassium has greatest chronotropic effects, right? Hyperkalemia causes excess potassium diffuses into the cardiomyocytes. Myocardium becomes less excitable, heart rate slows down and becomes irregular, right? Hypokalemia, deficiency in potassium, cells become hyperpolarized, requires increased stimulation. Listen, guys, you see, when you give too much potassium to someone, it has that effect of slowing the heart down because it's too much at a time. If you give it slowly, it will help the heart to contract normally. But if you push it in, that's why KCL, they use KCL to kill people without trace. If you watch these movies, you see the person dressed like a doctor and come. Just come inject something there. Immediately inject something there. Bam, the person is dead. Somebody say you can't hear me. Hello? Is it only you? Hey. Can you hear me now? Can you hear me? If you can hear me, say yes or no. No. I need you to type. Yes or no, if you can hear me. Yes. Okay. Ha, you guys scared me. I was wondering. I say, what happened? You can hear me. Okay. So that means the person that cannot hear me is from your own end, all right? Try to sort it out. Okay, guys. Thank you. So potassium has the greatest chronotropic effect. So you remember that. Calcium also is very, very important. So you need to know what happens in hypercalcemia and hypocalcemia. That's deficiency and too much. And hyperkalemia, deficiency and hypokalemia, hyperkalemia and hypokalemia, that's too much and deficiency. You need to know how it affects the heart. You understand? Extremely important because they will ask you. All right. Now, the other factor is the stroke volume is very, very important. Apart from cardiac output, we discussed cardiac output. Stroke volume is very important. What determines the amount of blood that comes out of your heart. The amount of blood the heart pumps. What determines the volume? Amount of blood, the volume of blood that pumps out. Three things. So three things govern the stroke volume. Thank you. Three things govern stroke volume. One is preload. Two is the contractility. Three is the afterload. Preload, contractility, afterload. They will ask you this in the exam. One of the following does not affect stroke volume. Please, these are the major things that affect stroke volume. Preload, contractility, afterload. When preload is increased, when contractility is increased, stroke volume is increased. So you need to also know how these things affect stroke volume. But when afterload is increased, it decreases what? Stroke volume. Yes. I'm done with chronotropic effects. Now we are talking about stroke volume. We say three things affect stroke volume: preload, contractility, and afterload. Think about it. Think about it. The normal class is supposed to finish by 6 o'clock. No, by 6:30. That's normal class. But I'm finishing in the next 20 minutes or less. Your YouTube is always late. I think it should be your gadget that you are using. Why I'm saying it is because as of last semester, I was using this my pretty laptop here, my sweet Samsung laptop here. So last semester, and people that were with me last semester, they know I was always lagging behind. I was always so slow. You know, they understand. But miraculously, the Lord gave me little money for me to buy a new laptop, and since then I've not had a problem. All right, so we praise the Lord, people. Okay. So that's sorts. So guys, please, do you remember preload? Okay, let's do this. I'm thinking of something to do demonstration with now. Okay, let me use my phone. Is it charged? Yes. So guys, look at it. Preload. If I push this phone like this, boom. Or no, let me do it like this. Assuming I have this phone like 10 of it, 10 of it, and I push it like this. There's no resistance in front. I push it like boom. What do you think will happen? A lot of the phone will fall over, correct? That's what we call preload. So when the preload, like if I now bring excess force and push it, you see, it moves faster and more than when I do it like this. So the higher the preload, the higher the stroke volume. Wisdom. People should remember. Preload is actually the fluid that enters the heart. So if there is a lot of fluid coming in, there will be a lot of fluid going out. That's preload. Listen, guys, if you can catch this thing, I see somebody eating. What are you eating? Your brain is doing double job, listening to me and eating something. Better keep that food, though, or you bring it to Staten Island. Okay. Preload. When it's too much fluid, like when there are a lot of fluid coming into the heart, there will be a lot going out. In a normal system. Remember I said normal system. There will be a lot going out. So a lot of fluid coming in is preload. A lot going out is stroke volume. Same thing with contractility. You already know that one now. When it's contracting, if you contract faster, it's common sense. More fluid will go out. So higher contraction, more fluid goes out. That's stroke volume. Higher preload, that's higher push, higher fluid entering the heart. More fluid goes out. Common sense. You don't need to remember it in the exam hall. You don't need to think. Just pick your answer, move. I did not say move. I say move. You get, if you know it, you know it. It should be in your hand. It should not be in your notes, your book, I know somebody's busy writing what I don't know. Now, when you're talking about afterload is that resistance of that fluid, something that is stopping that fluid to go out. So imagine my hand now is blocking this phone from going this way, right? So let's assume this phone is the fluid, and this is the force or pressure that is stopping this phone from going out. If this pressure is increased, will a lot of this phone go forward? No. That's why the second thing there says increased afterload decreases stroke volume. Do your hand like this and say wisdom, wisdom. Wisdom wants to choke you people. Too much wisdom is with you guys. Too much wisdom wants to choke. Do you understand what I just said? I need you to understand the contractility, the preload, and the afterload, because they will not just ask you what are the variables that govern. No, they will ask you how does those the variables affect individual. Okay. Look at preload. The amount of tension in the ventricular myocardium immediately before it begins to contract. We already discussed that increased preload causes what? Increased force of what? Contraction. That's common sense. Common sense. Yes, wisdom. Too much wisdom. In excess exercise, it makes sense. Exercise increases venous return. So when you are exercising, your body is taking oxygen very fast away from the blood, and that blood has to rush back to the heart so that the heart can take it to the lungs. It gets oxygen and go and distribute again because you are doing exercise, you are doing activity. So what does it tell you? It tells you that exercise increases the amount of fluid coming back into the heart. That is increasing preload. Remember, I told you preload is that fluid that comes back in. So exercises increases venous return and stretches the myocardium. Cardiomyocytes feels the tension, and what do? They increase the cardiac output to match the input. So if 10 liters is entering, 10 liters is going out. That 10 liters going out is what? Is the stroke volume. That is preload. Here now they are talking about Frank Starling law of the heart. SV is directly proportional to EDV. You understand? That means increase in stroke volume increases in leads to what? Increase in end diastolic volume, because it's equal. What is going out has to be equal to what is going out is EDV, and it's stroke volume. What is coming in is EDV. So if the end diastolic volume is 10 buckets of water, of blood, then what is going out has to be 10 buckets of blood. That's SV is equals to what? EDV. That's stroke volume is directly proportional to end diastolic volume. Increase in this leads to increase in this. Decrease in this leads to decrease in this. Common sense. In a normal system, pay attention, guys. I said what? Normal system. Because what you are doing is what? Physiology. And physiology is what? Location, function. The right function. Okay. This is contractility. Contractility is just talking about how hard your myocardium contracts. So if there's a lot of fluid in the heart, common sense, a lot of fluid in the heart is working very fast to what? Push it out. Contraction increases. All right. So what are the things that can lead to increased contraction? We call them positive inotropic agents. They are agents that increases what? Contraction. Example, a lot of when somebody has a lot of calcium, hypercalcemia can cause strong prolonged contraction. You understand? Which can even be a problem to the heart, lead to cardiac arrest. Other things is catecholamines. We already discussed catecholamines like norepinephrine. What does it do? It increases calcium levels in the heart, leading to what? Increase in depolarization. That's contraction. You understand? What about glucagon? Glucagon stimulates what? CAMP production. Remember, CAMP is second messenger. CAMP increases what? Calcium. You understand? Then this drug, digitalis, it raises what? Calcium. So anything that raises calcium will lead to what? It's a positive inotropic agent. increasing contractility. So hypercalcemia, catecholamines increases calcium, glucagon increases CGMB, right? Which increases what? Calcium. This your face is not fine now. Don't worry, we have just a few slides to go now. So when you talk about negative inotropic, we are talking about just opposite, like hyperkalemia. Guys, hypercalcemia causes positive inotropic. Hyperkalemia leads to what? Leads to what? Negative inotropic. It reduces contraction. Don't think the two hyper increases. No. Hypercalcemia, high calcium, leads to what? Increased contractility. That's positive inotropic. Hyperkalemia, high potassium, reduces what? The amount of calcium, because potassium works opposite of calcium. Reduces the amount of potassium. Do you understand? When you reduce the amount of calcium, right, it leads to what? Reduced contraction. So hyperkalemia causes low calcium, reduced contraction. Before you even talk about vagus nerve. So what have we discussed? Preload, right? Guys, we've discussed preload. And we've discussed what? Contractility. And we have afterload. Don't worry, we have like 7 slides to go. Or do you want a break now? If you want a break, say yes. If you don't want a break, say no. Quickly, guys, quickly. You have to talk. I need like 10 people to talk here to make sure that I'm talking to people, human beings. Nobody yet? Ha! This class, you guys are... If you want break, say yes. If you don't want break, say no. Ten people has to comment too before I continue. One, two, three, 4, 5, 6, 7, 8, 9. One more. Okay, so no break. All right. Now, afterload is the sum of all the forces opposing ejection of blood from the ventricle. I've already told you. Blood wants to go out. You understand? Something is stopping it from going out. If that thing stopping it from going out increases, the amount of blood going out will reduce. Simple. That's afterload. You get? So largest part of afterload blood pressure is the aorta and the pulmonary trunk. So the aorta, the pressure in the aorta and the pulmonary trunk limits stroke volume, opposes opening of semilunar valves, right? So hypertension increases afterload and opposes ventricular ejection. You understand? So you need to know this example. Other things are things like lung diseases that restrict pulmonary circulation. Emphysema, chronic bronchitis, black lung disease, all these things are usually, so that's why most people that are smoking, they'll usually have a problem later in life. All right. Okay. So very fast. We're almost done, guys. We're almost done. So these are just exercise things that we've already mentioned. Let me see if there's something I need to talk about. Coronary artery disease, we already mentioned it. You understand? Usually as a result of atherosclerosis and accumulation of lipid deposits. So like me now that I have hyperlipidemia, I am a candidate for coronary atherosclerosis if I'm not careful. You understand? Like now I'm trying to do a lot of things, eat a lot of things that will reduce my lipid. But in the next 4 months, if I go to the clinic and I check my lipid and it's still high, I'll just tell them to give me atorvastatin, to reduce the lipid by a drug. Do you understand? Now, no problem, no much problem because I'm still young. But assuming I'm much older than this, right? And this condition happens, they are placing me straight up on atorvastatin. Do you understand? So coronary artery disease is a constriction of coronary arteries. And do you remember what I told you? This is a sequel. I told you that could happen. Atherosclerosis, when there's accumulation of lipid deposits that degrade the arterial wall and obstruct lumen. All right? Blood cannot even pass through. You understand? Usually starts as a result of what? Hypertension, diabetes. You understand? Diabetes, hypertension can cause atherosclerosis. Unfortunately for me, I don't even have any. You understand? I don't have any. So that's the thing. So CAD is one of the things that could happen, and you guys should try to think about it. Usually for your exam, this is anatomy. We hardly give you physiology questions, pathology questions. Anatomy and physiology, we hardly give you pathology questions. But you need to know that when something is not normal, it becomes what? Pathologic. All right? Normally, lipids are not supposed to be deposited in those blood vessels. But when they start being deposited, it starts blocking the coronary, and initially the patient will be having angina pectoris, usually, right? The person comes to the hospital and complains about chest pain. We already discussed this in the course of this discourse. Do you understand? And if the person doesn't do something about it, it can lead to cover up and cause CAD, which becomes a problem. All right? And CAD, coronary artery disease, will cause infarction, and infarction will lead to what? Heart failure. So this is a sequel. Right? See what I said? Causes angina pectoris, intermittent chest pain by obstructing 75% more of the blood flow. Now imagine if it blocks 100% of the blood flow. So the blood getting to that particular muscle that it is supplying, right? Will be cut off. Interruption, stroke. That stroke in that muscle is what we call what? Myocardial infarction. Very, very important to know. You understand? Sometimes immune cells will lead to rupture. Will cause rupture. You understand? And that rupture, you see, when that blood clot forms, that the fatty clot forms, the rupture, the immune system, we want to cut it out. It will cut it out. It will, the clot or emboli will start traveling. Some of them will go to the brain and block it, causing stroke. That's what happens to my dad. My dad was never hypertensive or diabetic. But because he was not taking some things, I think we have a lipid in our family. So because of that, he didn't take care of it. And I think that's what happened. There was a rupture, and that rupture traveled to his brain and caused clots, leading to his stroke. You understand? So, okay. So that's the thing. So these are major risk factors, you see. LDLs. Exactly LDLs, low density lipoprotein. So guys, please go to the hospital and do lipid profile. Can you believe that this is hey Jesus, I'm ashamed to say this thing. This is the first lipid profile I have ever done. And the only reason, one of the reasons I did it was because my dad just died. And I know that this is the only thing that could have led to his stroke. So I was telling myself, Nchebe, you have to go and do lipid profile. You need to know. You think you are very, sometimes you think you are so fine. See me, I'm very, very active. Forget my leg, guys. Don't look at me like a disabled person. I'm not disabled. Forget about my leg. I am a very, very active person. I can stay here with you for the next 10 hours. No problem, no shaking. Do you understand? But I went to the hospital, and if you see the quantity of LDL in my system, it's too much. Like the doctors were like, wow, what? Are you all right? What are you eating? I don't even eat. I really don't eat. You get? So that's why I was telling you cannot meet somebody on, even if the person slaps you, leave the person. Don't beat the person with anger, because one punch and maybe the person is having angina, and because of the high rush adrenaline, it blocks that place, cuts off blood supply to the brain. The person has an immediate stroke, and maybe unfortunately for you, the person can just die. Murder. You understand? They'll just take your nursing degree and keep it in the fridge, and I'll be coming to visit you in the prison. So please, guys, please. So go, first of all, go do your lipid panel test, and please don't fight anybody. No matter the provocation. I was watching an Instagram clip yesterday. That was yesterday night, of an elderly woman around 80 something years. But she's very agile because she was working on her own. She's very elderly. She has body. Came to the counter and was complaining. The CCTV camera was showing where she was very aggressive. Then somebody touched her. She now pushed the person. Then one little young lady like that now pushed her, and the woman fell on the ground. Guess what happened? That one that pushed her was busy shouting. They were holding her, shouting. The woman stood up and she was talking and she collapsed and she died. Now that girl is in murder trial. You see? Like, number one, why will you even fight somebody that's old? A senior citizen. Are you crazy? Number two, why will you even fight anybody? What's that for saying? But that's the truth. Why will you even fight anybody? Not talk of somebody that is that age. Like, go fight your mates if you really need to fight. I have to fight for me to get oxygen. Go fight your mates. You are fighting an elderly woman. No matter what that woman does, some people in the comment section were like, don't you see that the elderly woman provoked her? I was like, you are just talking because you are with your computer. Go do the same thing. Now the person you are supporting is in murder trial. But it's possible that woman she's old, so she already has a lot of comorbidities, waiting for just something to trigger. The only thing that they need to prove now is that push cost, her death. That's it. And she's gone. Throw away her life. Somebody that's 22 years. Please, I don't want to talk about some people that are very dysfunctional. Anyway, not to be judgmental, go do your panel test, all right? So that you know to avoid risks like me now, maybe heredity, not aging, definitely, and also being a male. These are unavoidable risk factors. So you guys, if you are a female, biological female, if you're a biological female, trust me, you have less risk from having coronary heart disease. All right? If you check, a lot of men die of this coronary heart disease, not women. And it's usually very elderly people. That's why they didn't place me on an atorvastatin. They want me to try, and it can be hereditary. That's why you see somebody that is normal, living very well, eating the right food and still have it. These are the preventable risk factors: obesity, smoking, lack of exercise, anxious person. Now imagine that time I was weighing 225. I was seriously obese, grade 1 obesity, almost moving to grade 2. I'm imagining how high my cholesterol is then. So guys, you need to go check so that you work on yourself. No matter, even if you are slim, don't think you don't have high cholesterol. Obesity, smoking, people that smokes, I know a lot of people here smokes because of the code and some other flimsy excuses. Lack of exercise, right? Some people don't do exercise because they're doing double jobs. A lot of nurses fall into this category. Anxious personality. You understand? Some people are unnecessarily anxious about exam. You understand? Somebody called me yesterday. They have exam tomorrow. Called me, hey, professor, hey, this one. I said, don't be anxious. Just relax. Anxiety can make you even fail your exam. All right? Then stress. Don't let anybody stress you. You understand? Today in the hospital, they are telling me that I am having a surgical stress. That's what the doctor said. That's his diagnosis today. Say I'm having serious surgical stress because they checked my body. My blood pressure was spiking up more than usual. I don't understand how. Me, that is so chill. Anyway, and diet. I've never seen a wife that is casting their husband in public. But okay. So when someone has coronary artery disease, we can do bypass, we can do ballooning or laser angioplasty and insertion of stents. A lot of people have stents in their body, you don't know. All right. So I think that is the end of our discourse. You guys are the best. We spent 3 hours, 30 minutes. So you see why I said it's very fast. Because if I'm in class, I am sure 5 hours will not be enough. It will not be enough for me, 5 hours, if I'm in class. All right. So you guys are the best. So please Go and if you finish watching those videos I posted, go and look at the lives. I'll look for it. I'll see a way if I can post the lives for you. Take those lives and watch it. It will not kill you. All right. Let me tell you, some people even take pen and paper and write down the question. They take pen and paper and write it down. That's what I will encourage you to do. Because when you take pen and paper, I say teachers give us stress. It's not teachers that give you stress, it's bills that gives you stress in America. Trust me. Teachers here are so chill. In the US, if you are complaining of US professors, go to Nigeria and you understand what I'm telling you. They choke you. They take out the remaining oxygen that you are breathing in Nigeria. This is what we are doing here. Yeah, professors are chill now. We are so chill here. See me now, very chill. No problem. I don't want anybody to fail. Do you get? In Nigeria, professor will not come to class. He will tell you to go and read it up. And he will give you in the exam. You understand? I did surgery and I'm here teaching. I can easily cancel this class. So yeah, professors are so chill. You get? So guys, please go and study. Please. Please go and watch those videos. I've tried to make life easy for you. Just the 3 chapters, that's what you see in the exam. All right? So that's the end. Does anybody have any question for me? Any question for me? Somebody said I lost weight. I don't think I lost. Me that has been in the house eating. But they are buying me everything from New Jersey to Brooklyn. After you were not here, I said that we are not having reviews. Go and watch the videos I posted and also go to my my YouTube channel. I said Instagram. Hey, Instagram has entered my head. You know, sometimes I can be in Instagram just laughing and laughing like a terrible person. Anyway, that app is so interesting. A lot of reels. Anyway, guys, please go on my YouTube channel. Go to the live session. You will see exam 1 for anatomy 2. Go and watch it. Just make sure it's your topic. Thank you so much. Go and watch it. Please. You see how I'm begging? I really don't think I will have the strength to take class, all right? Also, guys, go and register for tutoring. Please. I'm serious. I'll send you the email address of the person you're going to send message to. I think somebody send it to you. Felipe send it to your class. You should send message to her that you need tutoring. It's very, very important so that, you know, some of the tutoring times I can be using it for your reviews. All right. So that it will be official. All right. Please do it today. Like, just send that message today, no matter how late it is. Thank you, guys, so much. And I appreciate all of you. I wish you the best next week. Please don't forget. What chapter again? Chapters. I don't know the chapter by heart, but it's the first 3 chapters. Let me see. Oh, boy. And yes, I've taken the attendance. I see that everybody came around today, so that's fine. The chapters is chapter 17, chapter 18, chapter 19. Yeah, 17, 18, 19. Yeah, thank you guys so much, and I see you next week. I'm even still going to the hospital tomorrow, Seth. I'm so tired, man. And I'm supposed to take a class tomorrow, but to the hospital. Okay, guys. I have a nice one. I'll see you later. Later. Today is 21st, yes. Sorry, I wanted to capture the attendance stuff. Yeah, you're welcome. Thank you so much. Yeah, definitely I'll be back next week. I'm feeling sick again. I don't know why I feel like this. I don't like this feeling. All right, thank you guys. I'm gonna go off now. In the next 30, I'll count 30, then I'll go off. One, one, two, three, four, five, six, seven, eight. Thank you. 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 21, 22, 23, 24, 25, 26, 27, 28, 29, 29, 30. Okay, yeah, take care of yourself, guys. I appreciate it. I'll see you next week, all right? Have a nice day. I'm going to go off now. Yes, bye bye. I don't even know how to. How do I go off? Okay, end stream. YouTube has changed a little.